It is a great pleasure to welcome all of you. Thank you very much in Saturday afternoon in Japan. So we are so honored to receive all very experts of the trauma, neurotrauma territory. Yes. And many of the young doctors, I think, link soon. I think so. We are very much looking forward to your lecture. Maybe you can give them some good tips or some knowledge or some skills sometimes. Thank you so much. Thank you very much. So let's start. I think the first speaker is Professor Gregory. Are you ready?
I am.
Okay, thanks. So his talk today is a new penetrating head injury guideline by the BTF. So thank you very much, the Gregory. In
All
Japan,
right. Well,
very seldom. Japan is very seldom. Okay, thanks.
very good. Well, it's a tremendous pleasure to join you this morning. It's just after midnight here in Ohio, and this is a tremendous venue. It's a tremendous pleasure and privilege to share a virtual podium with such eminent people. So it's my pleasure to share what's become a very hot topic recently, and that is the issue of our brand new penetrating head injury guidelines that the Brain Trauma has been working on actually for the last 5 years. I think all of us recognize that even amongst expert physicians in neurotrauma, penetrating head injury has a special place. These are amongst the most complex injuries that we see, and they're also highly emergent. So it's that combination of complexity and high pressure to act that I think makes these very difficult injuries to tackle. And I have to say that in my experience, these are often some of the worst managed cases. And I think it's because these are often very dramatic and frankly, distracting injuries. So when you see a gory wound like this come into your emergency department, it's very easy to forget about the ABCs and the ETLS protocols that are usually so ingrained in our practice. And it's for a lot of us outside of the military, we maybe see, a few of these a year. So it's very hard for us to accumulate much wisdom and experience with these. And certainly we all know that many of these patients have complicated vascular injuries. And so if you're a neurosurgeon like myself, that's not a vascular neurosurgeon, we know that this can really be a kettle of fish that may require additional assistance, and it can be a real problem. And it may not be fair to say that there's been a lack of guidance. I want to be very clear that we're building upon a prior first edition guidelines. It's a very rare guideline document that it doesn't come from the Brain Trauma Foundation. It's published back in 2001, but it's not a very well-known set of guidelines. So I think a lot of people perceived at least a lack of guidance in managing these cases. Now, I'll tell you that 5 years ago, when we first conceived of this project, the world was a different place. Back then, I never would have thought that we could have another war like we're seeing right now. And in fact, to have 2 of them right now, for me, has been very heartbreaking. And, whenever you write a guideline document like this, you hope that no one will ever need to use it. But the fact that there's been such a strong need for our guidelines has been, very unfortunate, frankly. And I will say that normally I would be very reluctant to give a talk where we're releasing data before it's been published. But in a time of war, we've recognized that we have a product that's effectively already peer-reviewed. We've got a panel of over 30 world experts in the topic. So we've been agreeable to presentations like this and to early dissemination. And I'm working now in America at the Cleveland Clinic, and I'm reminded on a daily basis that the world is changing in other ways. So, there's a mass shooting somewhere in America at least once a day now. So penetrating head injury really is of unfortunately increasing importance in the world. The only group of people that really gathers much experience and expertise for this is the military. And there's been a really important military to civilian translation that has occurred over the years. The last one that I think was really important was in part the Lebanese conflict and lessons learned in Vietnam, where previous to those conflicts, there was very radical brain debridement and an attempt to get every little fragment of bullet out. We've since learned that wrecks people and isn't really advantageous. So that got brought over to the civilian realm. The other really important thing that we've learned from the military, we need to all understand that military patients, despite being shot with higher caliber weaponry, have better outcomes than civilian patients. And that can be for several reasons, but I'm going to talk to you a little bit about why we think that may be. But really, the military is very intimately ingrained in this work. And in fact, how this project came about, so many of you will know that I was involved in the construction of the CBIC algorithms. And we just launched them, Randy Chestnut and I, and my other favorite Randy Bell, who at the time was the chair of neurosurgery at Walter Reed, came up to me and said, "Hey, Greg, you know, the CBIC was really good. Do you think we could do that again, but for penetrating head injury? There's nothing like that for penetrating head injury." I said, "Well, I think it's a great idea. Let's not just do algorithms, let's do a full new guideline." So we actually asked permission from the authors of the first edition, and they said, "No, we're not going to update it." And we proceeded to do this project starting again about 5 years ago. I also want to be very clear that a lot of the work that I'm about to present really is Randy's work more than it is mine. And I also want to make clear to everyone that this work is dedicated to Randy's father. Randy Bell's father was a police officer in the Baltimore Police Service, and he was shot in the head and died in the line of duty when Randy was 3 years old. And that has motivated Randy to do many of the things that he's done in his life, including these guidelines. So these will be dedicated to his father. So now to talk a little bit more about the guidelines. So these are going to be coming out hopefully this fall in neurosurgery. We're going to be publishing this as a full separate supplement. This is a partnership. The first guideline we're publishing is part of a new partnership between the Brain Trauma Foundation and the military's Military Traumatic Brain Injury Initiative. So they're providing lots of funding, and we're going to be doing a lot of guidelines with them over the next 5 years. And here's the people that really get all the credit. So Randy and I, you know, tried to really bring out all the talents of the people that you see here. And it's all the people that you would want to have. You know, we've got Bijan Arabi, who was a neurosurgeon in the Lebanese conflict and has worked his whole career at shock trauma. You know, we've got half of the people in this group were active service military. And of the half that are civilian, half of those are retired military. In here, you can see just behind me is Rocco Armanda, who has been twice deep within Ukraine in the last year, helping with the neurosurgical care. We've got Guy Rosenthal, who's of course very busy in the Israeli-Gaza conflict right now. So really the sort of people that you want to have at the table when you're doing these sorts of guidelines. So this is going to be a much bigger document than what the first edition guidelines were. So far, it's at 350 pages, and we've decided to cover the pre-hospital domain, including the emergency department. We've covered a very robust section on surgical management, and an additional subject or aspect of this will be on intensive care. We're also publishing a series of algorithms. We've got a master care pathway. We're also publishing a futility assessment. And then we've got what we're calling toolkits. So if you've got a particular problem, we've got an algorithm that might be suitable to help with that particular problem, but not everyone will have it. What is very, very important, so the Brain Trauma Foundation listened to the criticisms of our fourth edition. People said it's too sterile, it's just legalese recommendations that speak of evidence, doesn't tell us what to do. So we decided, especially on this project where there was such poor evidence, that we had to provide concurrent expert opinion. So we've tried to very carefully label it, to sort of wall it off and separate it from the evidence. But it's the first BTF guideline that has brought together evidence with expert opinion. So we'll be very keen on your feedback in terms of how you think we've pulled that off. So here are the key changes. So I'm not going to have time today to go through all of the new recommendations, but I'm going to try and go over the important themes and a couple of the important recommendations. Really, we've chosen to focus very much on neurovascular injury. It's really the defining characteristic of penetrating head injury far more so than in blunt injury. And it's one of the reasons we did this. I've noticed amongst very eminent, prominent neurotrauma neurosurgeons, there's been very diverse opinions on how to handle pseudoaneurysms, when to screen for them, how to screen, if you should screen, and how to treat them. And so we brought everyone together, and the agreement was that we need to be very attentive to these. We need to screen early, screen repeatedly, and aggressively treat these. We're recommending the use of angiography, formal catheter angiography over CTA as much as possible. And perhaps the most important point is that we're now recommending endovascular treatment for these lesions over open surgery when it is feasible to do so. As opposed to the first edition that said everyone should get prophylactic antibiotics, we're recommending them only for select patients. And one of our level 2 recommendations, these are very rare level 2 recommendations in neurotrauma. We have evidence to support a level 2 recommendation for achieving a watertight dural closure for reducing morbidity in these patients with surgical care. And perhaps most important of all, although it's hard to find papers that support this, is the idea of avoiding nihilism. So a little bit more on this issue of neurovascular injury. So I trained at the University of Toronto, a major neurovascular center, and our teaching when I was a resident was that you can't coil a pseudoaneurysm. It doesn't have a wall. It's just clot. You put coils out into free space. Doesn't do anything. But our colleagues in the military have shown us that that is not true. You can coil a pseudoaneurysm. And in fact, the benefit to coiling these is that you can potentially preserve the parent artery and avoid a stroke. The one issue you need to be aware of is there's a very high rate of recanalization. So these often have to be retreated. About 2/3 of them have to be retreated. But we think this is now perhaps the best way to manage these. So even this patient that I showed you at the beginning, this patient had 2 pseudoaneurysms. This was managed with parent vessel sacrifice. Again, these are potentially devastating, life-threatening lesions, and we're trying to bring everyone together to realize these need to be detected and treated aggressively. The second really major point, we talked to the military guys at length, and we said, why is it? Why are your patients doing better than the civilians, despite the higher caliber weaponry? And the conclusion was that it was because of their extreme aggressiveness. The military it's a brotherhood, and they're out to save the guy that they had lunch with. They will stop at nothing to provide them with the best care. And that is probably the single most important factor in these patients in terms of getting the best outcomes. We had the general principle that probably there's one best care, but we did say that if there's evidence to treat, different genders, people of different ages, people with different wounding mechanisms, or military versus civilian patients differently, we were looking for any evidence that would support that. We actually found very little. What we did find suggested, maybe differences for pediatrics. So with the time that I have left, I'm going to show you a little bit of a sort of a sampling of some of the new recommendations that are going to be coming out. So in terms of screening, we're not very keen on X-ray. It still has a role, but really CT is far better. And you can think of cases where, there's been a knife wound to the head, the knife is pulled out, an X-ray is not going to find that. So CT is really the priority imaging. And that's a problem when you're in the military, because CT scanners are not always always easy to come by. There are many different prediction models that predict outcome in penetrating hand injury patients. Probably the most well-known is the SPIN score, but there are others. And many of these actually perform quite well. So I wanted to share with all of you that we had a major debate about how to handle this. So I think we're going to be revising the recommendation that you see here. There's been a real concern amongst our panelists that people might use these predictions to fuel nihilistic views and nihilistic care. And that's a paradox, actually, because most of these prediction models were made to discourage nihilism. So I think that probably we're going to write a recommendation, not saying that you shouldn't use these calculators, but they shouldn't be used to withdraw care, and that avoiding nihilism is critical to getting the best outcomes. We think that it's very important, and the evidence supports that it's very important to screen for pseudoaneurysms, screen early, screen repeatedly. Again, you want to do a second screen at 7 to 21 days after injury, because some of these develop late. and treat them aggressively. Identifying and treating them reduces morbidity. You can use CTA, but in most instances, we think that formal catheter angiography is superior both for detection and allowing you to treat these lesions. In patients that have a higher risk of vascular injury, people with the characteristics that you see here, perhaps it's best to just go straight to catheter angiography for them. Certainly patients with streak artifact or where CTA is of insufficient quality, and even if you do detect an injury or a lesion with a CTA, then we recommend following that with a catheter angiogram. We're now recommending antibiotics for most patients, not for all patients. So if you have a dural violation and a clearly contaminated wound, or any patient undergoing a procedure, those are higher risk patients for infection. And of course, most of these patients will be undergoing surgery. With respect to surgical care, some of the highlights. When surgery is indicated, perform it early. This really comes out of some of the military literature, and they specify a period of 4 to 5 hours as being the target. And if you need to transfer a patient to get neurosurgical care, do it as soon as possible. Not all patients need an extensive surgery. So we think that in some cases, if there's minimal disruption of the skull and brain, a local wound debridement and closure is acceptable. In these patients, though, we really have to follow them with serial imaging, make sure they don't get an abscess. And certainly in a mass casualty situation, this is even more permissible. Reiterating what we learned from Bijan Arabi, that we certainly don't recommend extensive debridement. Take what comes easily. If something gets infected, then you go in later and take that out. We only want to be removing protruding foreign bodies, things like knives sticking in the head, either in the operating room or the endovascular suite. If fragments are migrating within the head, they can cause further damage and may need to be removed. And certainly if they're at a nidus of infection. Here's that very important level 2 recommendation to try and avoid CSF leaks. And the really important pearl here is that as compared with a blunt head injury associated with a CSF leak, these are usually gaping wounds. These are not going to heal spontaneously. They usually require a surgical repair. And a lot of us are hesitant to put in foreign bodies, foreign material, things like dural substitutes that don't have a blood supply, but the literature really tells us that it's far better to do that than to risk a CSF leak, and that's, I think, going to be an important learning point. With these pseudoaneurysms, again, we're encouraging endovascular treatment, but if you can't do that, if it's not favorable, open surgery is still very acceptable, and there's a lot of literature supporting it. Again, treating these lesions aggressively if they're growing in size, and if they're larger, we think those are at higher risk for rupture. And if you do coil these pseudoaneurysms, you need to repeat your angiography within 8 weeks to make sure you don't need to retreat, because 2/3 of them need to be retreated. Very controversial. We talked about, is there any circumstance where it's acceptable to sit on these lesions even temporarily? And we agreed that in select cases, if you're worried about having the resources to do it safely, the sufficient expertise, or you're worried potentially that you could cause a stroke and eloquent cortex through treatment, then it is permissible to watch these. Some of them can regress spontaneously, but in general, our panel was really not in favor of that. Just going to show you the intensive care recommendation for seizure prophylaxis. We think that these patients are higher risk for seizures, so we want to treat for a minimum of 7 days with anticonvulsants, although we don't really have evidence for agent, as we don't currently for blunt head injury. And I'm not going to go over these in detail, but do want to share with you the algorithms that we've constructed. The general principle behind these algorithms is that we're trying to ensure that patients are treated in the right environments, that care is not nihilistic, and that we're anticipating problems, and that we're adequately resuscitating. We're considering the extent of surgery. For instance, do we need to prep the neck? Is our craniotomy big enough? We don't want to be halfway through a surgery and then realizing we didn't sufficiently consider those things. So these algorithms are really designed to help a neurosurgeon at a time of crisis, where you've got a patient with something sticking out of the head or they're bleeding to death. You have to treat these patients often very rapidly. So we're trying to give something that a surgeon can hold in their hand and work through fairly quickly, and something that helps them tremendously in their patient in a time of crisis. So here's the master care pathway. So this is going to apply to every single patient. Won't go over it in detail, but it walks through all the different stages of care. It alludes to the different toolkits that may be relevant at different points. Again, emphasizing things like proper resuscitation. Again, very controversial in our group was the issue of nihilism, withdrawing care, and there was a real reluctance to even talk about the issue of futility, futile care, and potentially withdrawing care or not being aggressive. The reality is that for most of these patients, we have to make a decision in the trauma bay, because if we choose not to operate there, these patients will die in a lot of cases. We played around with this for the full 5-day in-person conference, and eventually on the last day, we agreed we had to provide some guidance. And so what we eventually did, and we got 100% consensus on this, everyone agreed to this set of criteria for patients that no one in our group felt should be operated on. So this is a floor. This is the patient population that we really don't think would benefit from aggressive care. But what that also implies is that we think every other patient should be managed aggressively, at least initially, and be given a chance for probably at least 72 hours. We also have algorithms for surgical management, trying to get people thinking before they operate about the sorts of things that they might encounter, the sorts of things that they need to be thinking about. Do you need to prep the fascia lata, for instance, or prep for a fascia lata harvest? We've got an algorithm for complicated injuries, for skull base injuries, where we have to treat and prevent CSF leaks. We've got a protruding foreign body toolkit, a vascular injury toolkit. So we're currently in a third draft. We hope to have this submitted for publication within a month. The plan is for this to be published formally in Neurosurgery as a supplement this fall. And I'm very sorry to say, however, that this has already been rolled out in both of the major conflicts that are happening in the world right now. So I'm very sad to say that these are already being used. It is our hope that they're saving lives and leading to improved care. And certainly look forward to your feedback on this new Brain Trauma Foundation initiative. So thank you very much for the opportunity to share this with you today.
Okay, thank you very much, Gregory. It is a tremendous talk. We learned a lot from you, I think. So penetrating the injury is most, I think, difficult to understand the mechanism, how the power inside of the brain is affecting so many damage. But you mentioned about so many important things. But I think anyway, most knowledgeable, I think, important things we need as a neurosurgeon. So maybe we can take 1 or 2 questions from our audience. So, doctor from Bangladesh, please. Very short, please.
Yeah, very
just,
short. Thank you, Sinha.
just
Thank you,
one question,
Professor.
please.
There are many penetrating injury when there is ICH associated, and some cases only penetration of the weapon, patient clinically all right. So in 2 cases, how should we approach for the vascular evaluation?
Yeah, and this is a really tricky problem. And in fact, when we were in Bethesda at our in-person meeting, we talked a lot about a scenario where, on one hand, we're trying to push people towards angiograms and potentially endovascular treatment. But on the other hand, we've got patients that have mass lesions and that are in some cases they're in the process of herniating. And this for us was a real dilemma. And so you're going to see in one of our algorithms, as much as possible, we're trying to encourage people for the vascular workup ahead of time. and potentially endovascular treatments even before a craniotomy. Even if a craniotomy does have to happen, you know that. But there's going to be scenarios where when someone's starting to herniate, you just have to go to the operating room. And it's that second scenario where you just go and operate the open surgery. That's hard because you have to be ready with your aneurysm clips. I think all of us at some point in our career, some more than others, have seen horrific cases where we've got complicated vascular injuries. And that's where we have to use all our wisdom and training and surgical skill to try and save the life. So, I don't think there's a magic answer. But I think we are trying to push people more and more towards upfront, trying to figure out what you're going to encounter in the operating room and try and be prepared for it.
Okay. Thank you, Professor.
Thanks so much.
Thank you, sir.
Sinha from India.
Yes, yeah. There is a lot of controversy regarding the pseudoaneurysm, whether to clip or do intervention. So, what is our policy? Because most of the penetrating head injury, they are associated with a piece of bone or foreign body or debris, something. So, if we find any bone piece nearby the aneurysm, we clip, because post-operative chances of infections are very, very high. So this is our policy in our institute. We have a lot of patients with us. And second thing, what is your experience regarding the bleeding disorders? Because of thermoplastin activation, 97% patient, they have bleeding problem. So what is your experience? Can you share, right?
Yeah, I'll deal with your first comment first, and that is that I would strongly agree with you. The biggest priority with these pseudoaneurysms is to treat them. And there's a large body of literature. The gold standard still is open surgery. The reality is, in most cases, even though we're worried about causing a stroke when we clip and sacrifice these vessels, a lot of times that the cortex that vessel supplying is already damaged. So the important thing is, even though we're sacking the vessel, we're probably saving the life. And I agree the potential advantage of debriding the fragment that caused the injury can be very important. But we do think that the potential utility of endovascular treatment to save that parent vessel, we think that there's really going to be a shift towards that, and we're actually encouraging that shift. So I think the paradigm you speak of is highly acceptable and an excellent way to care for the patients. In terms of the coagulopathy, so we actually have a bunch of recommendations related to coagulopathy. We agree that these patients are higher risk for coagulopathy, even compared with blunt head injury patients that even themselves have a high risk. So we completely agree with the importance of screening and treating coagulopathy as rapidly as possible. The real debate that we had was around thromboelastography, the ROTEMs and the TEGs. And I think all of us agreed that ROTEM and TEG are absolutely options. I think a number of us have the view that sometimes the patient's physiology and the apparent coagulopathy doesn't necessarily always match with the TEG measurements. So it should always be used with a grain of salt, but couldn't agree with you more. As part of all the other things you need to worry about, correcting those coagulopathies is a very important part of getting these people better.
Thank you.
Thanks so much. So maybe Gregory, you had many very good teamwork, I think. Teamwork is very, very important. Sometimes do you do the surgery at the ICU site? What about your hospital?
Yes. So we have an entire chapter on multidisciplinary care. It was an entire PICO question in our guidelines. And that's absolutely the case where these are very complicated patients, even more so than blunt, because sometimes you need several neurosurgeons to do these surgeries when you need the vascular expertise. So, it's always complicated trying to find the resources. Fortunately, in Ohio, we see a few of these a year, but not what people, for instance, in Chicago would see. It's just a matter of for every patient, it's individualized. Some patients, we're into the endovascular suite and in the operating room. So certainly we're doing a lot of our EVDs and things like that in the ICU, but most of the work we're doing as a team in either the endovascular suite or the OR.
Okay. Thanks so much. So maybe we will invite you again and again. So please teach us more, please. Thank you so much. A wonderful talk.
Thanks
very much.
Thanks for the privilege.
Thank you. So maybe then we move to the next talk. Professor Eichi Suehiro from Japan, Tokyo. And today his talk is standardization and the collaboration of the head injury treatment in Japan among the neurosurgeons, emergency physicians, and intensive care physicians. Suehiro Sensei, please.
So thank you very much for this time invitation, this excellent meeting, and now I'm very honored to be here with excellent professors. So today, my topic is standardization and collaboration of head injury treatment in Japan among the neurosurgeon, emergency physicians, and the intensive care physicians. As you all know, when treating head injuries, we go through a variety of situations. It starts at the accident site and the emergency service arrive and perform treatment at the scene. After being transported to the hospital, appropriate initial medical treatment will be performed in the ER room, and if necessary, surgery will be performed. The patient will receive intensive care in the ICU, and once the patient's condition stabilizes, the patient will be transferred to rehabilitation. In this way, it's important for the various steps to transition smoothly and seamlessly in head injury treatment. In order to improve patient outcomes, appropriate treatment is required at all steps. Each of these steps has its own purpose, and various professions are involved. For example, at the accident site, the goal is prevent secondary accidents. It's necessary for the police to control traffic and the fire department to organize the accident site. After the ambulance arrives, the patient's ABCs are stabilized and triaged by the emergency service or doctors and nurses. After arriving at the hospital, emergency physician and the neurosurgeon will perform ABC evaluation, resuscitation, and head injury assessment. If necessary, neurosurgeons will perform surgery to decompress and prevent infection. After surgery, neurosurgeons and intensive care physicians provide brain-oriented general care to prevent the secondary brain damage. Thereafter, rehabilitation is performed by a rehabilitation physician with the aim of improving physical function and cognitive function. In this way, many professions are involved in head injury treatment, and multidisciplinary collaboration is important in seamless head injury treatment. To achieve this, it's necessary to standardize medical care and share it among multiple professions. Therefore, we investigated the current situation in Japan regarding the division of roles in head injury treatment. A questionnaire survey was conducted targeting the training facilities of the Japan Neurosurgical Society. A questionnaire survey was conducted by mail in February 2022. The recovery rate was 55.2%, with the responses receiving from 480 out of 869 facilities. A similar survey was conducted in 2008, and the results were compared. First, the result regarding the division of a role in head injury treatment. the departments the department responsible for initial medical treatment were divided into 3 departments: neurosurgery and emergency physician and joint department. In 2008, neurosurgeons were primarily in charge, but this time, I mean, 2022, they are more likely to be in charge of initial medical treatment in the emergency department or jointly. Naturally, most surgeries were performed by neurosurgeons. Neurosurgeons are in charge of most of the intensive care, but recently it seems that more and more facilities are moving away from having neurosurgeon alone in charge of the care to working in collaboration with intensive care physicians. Regarding the division of role in head injury treatment, the current situation in Japan is that initial treatment is managed in the emergency department, and the neurosurgeons play a central role in surgery. And the neurosurgeons are also actively working on intensive care. Furthermore, neurosurgeons appear to be increasingly collaborating with emergency physicians and intensive care physicians. Since 2000, consistent standard trauma treatment has been established in head injury treatment in Japan, from pre-hospitalization to specialized treatment. In 2003, JPTEC was created as a protocol for pre-hospital treatment. In 2002, JATEC was created as a standard protocol for trauma treatment in ER room. And in 2000, guidelines for head injury treatment were created. JPTEC, pre-hospital treatment protocol, launched in 2003, emphasizes the following 4 points. Number 1, perform appropriate prompt observation at the trauma scene. Number 2, determine whether load and go is appropriate. Number 3, perform only life-threatening treatment. And number 4, leave the scene within 5 minutes for a medical institution that can perform appropriate treatment. JATEC, which started in 2002, is the standard protocol for trauma treatment in ER rooms. It's broadly divided into primary survey. It's an evaluation of physiological function and resuscitation for life support. And the secondary survey, it's a systematic search of the whole body. In the primary survey, after confirming the stability of A, it's airway and respiration and the circulation. After that, evaluate D, it means the central nervous system. Among them, there is a technical term called impending D, which suggests a brain herniation. After declaring an impending D, a neurosurgeon joins the trauma team. Head injury treatment guideline describes the surgical indication, timing, and the surgical method and the complications. Intensive care is described in the head injury treatment guideline, but guidelines from the Japanese Society of Intensive Care and the Neurocritical Care Society can also be referred to. Next, we investigated whether these guidelines are being used as a reference in daily clinical practice. The usage rate of ICP monitoring is increasing year by year. Additionally, the usage rate of neuromonitoring other than ICP monitoring is increasing. The implementation rate of body temperature management is also on the rise. Reflecting these results, awareness of head injury treatment guidelines has increased since the previous survey. The compliance rate with head injury treatment guidelines has increased from 81% in the previous survey to 97.8%. And it can be said from this survey that the medical treatment in Japan is generally conducted in accordance with the guidelines. However, since this is a questionnaire survey, the results are self-reported. As a result of increased collaboration with emergency physician and intensive care physician in head injury treatment and increased standardization of treatment within the team, treatment outcomes have changed as follows. Preventable trauma deaths are those that could be saved with proper medical care, predicted life-saving rate over 50%, but could not be saved due to neglect of them. This PTD is decreasing year by year. These results demonstrate the importance of us, neurosurgeons, sharing guidelines and participating as members of the trauma team. Finally, I would like to touch on the rehabilitation. Improvements in long-term outcomes after head trauma have been reported from the United States. 38% of patients also saw improved outcome. 12 to 24 months after injury. At 24 months after injury, 74% of survivors had a favorable outcome. In our Japan Neurotrauma Data Bank, the favorable outcome rate improved from 30.3% to 36.2% from the time of discharge to 6 months after injury. Discharge destination was cited as a significant factor associated with this improvement. In other words, the importance of rehabilitation during the subacute phase after head trauma is demonstrated. The importance of seamless head injury treatment, which I mentioned about at the beginning, has been reaffirmed. Summary. In the treatment of traumatic brain injury, the division of roles among multiple occupations is progressing. Neurosurgeons also need to share standard treatment for trauma treatment as part of the trauma treatment team. And it should be recognized that multidisciplinary team collaboration affects patient outcome. Thank you for your attention.
Thanks so much, Suehiro Sensei. The year result is the recovery rate is more than 50%, is very high. Congratulations. Also, you mentioned about the seamless the treatment and also the multidisciplinary. The collaboration is very, very important. Maybe I think the trauma itself in Japan is maybe much different from US or some other countries.
Yeah, that's right. Yeah.
So that means is I think we should learn more from another country's expertise. So we can take one or two questions. Dr. Sinha?
Any role of okay.
Please go ahead.
Yes. Any role of telemedicine in your place?
Yeah, I'm sorry.
Telemedicine.
Any telemedicine? Any role of telemedicine in evaluation or role of this in transferring the patients from accident scene to hospital?
Yes. So actually, in Japan, recently, the usage rate of telemedicine is increasing because Japan is not so big country, but so still a little. We have a region over doctor is not so many numbers. Yeah.
I understand.
Dr. Sinha, just you can tell us what's the exact meaning of the telemedicine, such as a kind of the robotics or telesurgery or teleconsultation or whatever.
In our country, it is very big country, and their pre-hospital care is very poor. So we scan the patient through telemedicine. We take advice from neurosurgeon, and then we go as per the neurosurgeon advice. So it helps in early transfer of the patients and patient care. So we have very good results in head trauma nowadays.
Of course, you can transfer the images also.
Yeah.
Thank you. Thanks so much. Lynne?
Is it me?
Yes.
Yeah, okay. Professor Eichi, how do you intend to monitor frequency of them being able to implement all of this? And number two, you have several levels of hospital care, right? So do you transfer from one hospital to the next depending on the geographical situation and capacity?
Okay, so first I will answer number one. In Japan, the most equipment of monitoring is ICP monitoring. And the number two is continuous EEG. And we hope that we want to use PBTO2 monitoring or something, but still now in Japan, we cannot use that. So actually, we can use ICP monitoring and continuous EEG monitoring. And number two, actually, so in this presentation, I'd like to say, especially to Japanese neurosurgeons, but severe outcome, especially outcome at the discharge of a severe traumatic brain injury, is not so good. I mean, it's bad. So, and almost neurosurgeons gave up. I mean, they transfer to the hospital. Actually, no rehabilitation, just die. So we need rehabilitation for at least during the subacute phase of a TBI. So it's my thought. Thank you.
So maybe Gregory, any comment to him?
No, I think that was a wonderful talk, and I really like how you're seeing more and more guideline compliance over time. You know, the really interesting thing when you look at, for instance, the Brain Trauma Foundation guidelines that I'm quite partial to, of course, there's now 4 studies that have shown that using the guidelines reduces mortality by 50%. That's been consistent, 50%. And that's been true in Eastern Europe. It's been true in New York State. And when you think about it, we're spending billions of dollars. We're trying to get a drug, and maybe what's going to be the threshold for a successful drug? You know, a 10% benefit. I mean, the reality is that you know, if we got a drug that improved mortality from head injury by 10%, that's probably a Nobel Prize. The guidelines have got us a 50% benefit. So I think it's very reassuring to see that in Japan there's increasing compliance. So congrats to you. And I think the lesson is the same as we found with penetrating head injury, which is that it's all about the multidisciplinary care. So congrats. That was a very nice talk.
Thank you.
Thanks so much. So Tariq?
Yes, thank you for an excellent presentation. I just want to point out to what Gregory said. In countries like us, lower middle income countries, we cannot look at the Brain Trauma Foundation guidelines. And what we are doing is, we have read the paper of Andres Rubiano from Colombia, and our commentary on that is resource-driven guidelines. So basically stratified protocols, layered protocols for management of brain injuries. I think that is very important for us to look at because reaching the level of the BTF would be very difficult. I also must congratulate you, Gregory, for presenting these guidelines or consensus statements, if I may say, regarding penetrating injuries, because we in Pakistan have been seeing a lot of blast injuries and firearm injuries, high velocity injuries as well. Thank you.
Thanks so
Thank
much.
you. So I know, so this is a case in Japan, so I can understand your opinion. Thank you.
Maybe Suehiro Sensei, you should visit the US or Pakistan sometimes. And you can see
Yeah.
it's fastest way, I think. Thank you so much. So we move to the next speaker. I'd like to pleasure to invite the Lynne. His part talk is advocacy, for neurotrauma care and the surgery in a limited resource setting, please. Lynne, please.
Yeah. Share my screen. My slide now. Here, okay. Okay, so my talk now is advocacy for neurotrauma care and surgery in a limited resource setting. So thank you again for this opportunity. Disclosure 9. So this is the place where I work. So the history is that 25 years ago, I started working alone, around 4 million people population. Started neurosurgery here in Bicol region. So nothing. I just came in with the basic craniotomy instruments. So still, the main cases are neurotrauma because it's a provincial setting. There's always a lot of motorcycles. And even though there's an advent of a lot of improvement in other aspects of neurosurgery, neurotrauma seemed to lag behind until just this last decades. So it's still a global health problem, and it's gonna increase as WHO has been saying, both the brain and spinal cord injuries. And the highest and lowest proportion of road traffic accidents and TBIs is in the African region, Southeast Asian region, 34%. And based on the one, the lowest is in the Americas, United States, and Canada. So in the Philippines, with a population of 117 million, we are an archipelago of more than 7,000 islands. There are 4.8 to 8.7 million vehicles or motorcycles. There was an increase of 10,000 of deaths from 2006 to 2015. The data is really out, not that recent because we don't have a neurotrauma registry yet. And again, still as reflected in other areas, this is the leading cause of death and disability in a lot of young patients. So what happens now in advocating for neurotrauma care and surgery in a limited resource setting? First of all, the awareness is also lacking. Unlike in other areas in the country, in the world, you have a lot of programs already and other registries, there's data. But here, there's none. We're still starting it. So back to traumatic brain injury, a lot of people just know the physical effects, okay, the motor, the sensory, but sometimes they're not aware that there's a lot of behavioral effects and even cognitive deficits that can be acquired from traumatic brain injury. So that's part actually of the advocacy, the awareness. So of course, the physical complications can be addressed by physical therapy, occupational therapy, neuro rehab, but still again, in a limited resource setting, even in Bicol, in the area where I work, there's only one rehab doctor. And the physical therapies are limited. We don't have a lot of occupational therapies. So how do you go about this? So again, the behavioral sequelae, it's just now that we are focusing on neurocognitive deficits acquired from neurotrauma. Before, a lot of people would just dismiss the behavioral as here in the Philippines, they will say he becomes angry easily because of he had an accident before, something like that. They just dismiss it. So they don't see it may be part of post-traumatic depression or something like that. They're not aware of that. So the recognition will come. If it comes, you will be able to seek help, not just self-help, but also group therapy. So sometimes here in a resource setting, I act not just as a neurosurgeon, but also in my clinic, I would act as a psychiatrist, also even counselor, and also rehab, teaching them, for example, physical exercises at home, what to do, the behavior, you would counsel the family to support them. And for children, you would encourage play therapy on how to mobilize again their limbs, and also those aphasic patients, voice therapy, and also neurocognitive rehabilitation. So what happens now is that, as Professor Eichi has been saying, there's a lot of, and Professor Gregory, or the previous speakers, there's a lot of collaboration now ongoing. So this is what we want also, what we need to do also even in a limited resource setting. We need to access all of these people to be able to create a team. So what we did is awareness first. So we created the Philippine Neurotrauma Bootcamp. So this was well attended from general practitioners. These are the things that we discussed, the plenary topics, nurses, EMT, a lot of even medical students. So we even had, it was held last year, and we had 220 face-to-face attendees and 1,000 plus via hybrid. This is Professor Virendra showing his famous egg, how the skull will break if it's not, you don't wear a helmet using the egg. So we had all this. We had Professor Virendra and Professor Punya as guests. So we had 1,052 unique viewers in day 1 to 3, most of them from Vietnam and of course the Philippines. Top 6 specialties were GPs, nursing, pediatrics, neurosurgery, general surgery, and neurology. So we had the double ASNS, the Asian Australasian, also via Zoom, and also the whole neurosurgical society participated. So what's next? We are actually having another bootcamp this May 1 and 2 to encourage cooperation from the emergency medical people to intensivists, neurologists, neuropsychiatrists, and even lay people, okay, and collaboration. So we are creating the Neurotrauma Society of the Philippines this May 3. So this will launch a website for education and awareness and advocacy. We will tie up with other neurotrauma societies. The Neurotrauma Society of India has already promised to help us. And we will participate in conventions with this new society. We will put up advocacy videos on road safety. And hopefully this will influence policies in neurotrauma and guidelines for the local government and other sectoral involvement. So from injury to recovery, a multidisciplinary team approach will come the Neurotrauma Society of the Philippines. So cooperation embodies the means to solving any problem we have. The resolute endurance to resolve should be there. So I would like to invite you all for the 18th Asian Australasian Conference in Manila in May 2026. Thank you so much for your kind attention.
Thank you, Lynne. So I think the multidisciplinary and also the collaboration is very, very important, and also the rehabilitation. Thank you so much. So any comment from Sinha? So you assist a lot for Filipino Neurotrauma Society, I think. Sinha, please. Unmute, please. Sinha, unmute, please.
I want to compliment Professor Lynne. She is doing a lot of efforts for care of the neurotrauma patient in her country. And in short time, she registered the Neurotrauma Society. And neurosurgeon is a very important part for taking care of the TBI patient. And I want to compliment just Dr. Lynne for his efforts.
Okay, thanks. So, thanks. So, Lynne, do you include the spinal injury?
Yes, this will be included in neurotrauma. Yes. We have spine neurosurgeons and also even both orthopods and neurosurgeons. They will be included in the whole care.
Okay. So maybe Petra, can you make some comment for her about the spinal injury?
Thank you, Professor Nato. So I think it's very important, like Dr. Lynne, because I see from the picture she's operating from B College, is quite a remote area, and I think it's very blessed for her area to have neuro rehabilitation and psychiatric support, things like that. I think it's very important because I think other than physical rehabilitation, we must also pay attention on the occupational rehabilitation and social rehabilitation, because even though they have a lot of spinal trauma, for example, some lumbar or thoracic fracture, they can still contribute to the society. And I think for a neurosurgeon, that will be our next step to integrate them into the working force again, especially in countries like Philippines or for me in Indonesia, because we need all of the people who can help. Thank you, sir.
Thank you.
Petra, how fast the rehabilitation involved for patients in your country?
So usually we will begin physical rehabilitation directly after the surgical treatment. So even in the days following the trauma, we will start physical rehabilitation. But mostly the patient will try to start occupational or mental rehabilitation 6 months to 1 year after the trauma, because sometimes they need to feel that they have a problem. They have a problem and they want to improve and they want to integrate into society again. And that's usually 6 months to 1 year. Usually they don't believe you in the beginning. They say, you have a problem. We want to help you. It needs time.
Okay, thanks. Tariq, any comments?
Thank you. Yes, unfortunately, the most important part, the rehabilitation, is very much lacking in our parts, and definitely the psychological rehab, which is again very, very important, and as just said, that something which people do not realize, and many neurosurgeons in these regions do not realize that that is one of the most important things. And I think it's really good to have, as everybody said, a multidisciplinary team with the psychologists, psychiatrists available on that team. Would be a very good start. Thanks.
Thanks so much. So the Aniak from Africa, please. Unmute, please. And yeah, unmute, please.
Yeah, thank you, Prof. Yeah. Good afternoon, good morning, good night, everyone. My name is Ikechukwu Aniako, a young neurosurgeon from Nigeria, and currently the ACNS African YNS Ambassador. Thanks, much appreciation to Professor Yoko Kato. Dr. Lynne, thank you so much. I drew inspiration in your presentation because your presentation is a reflection of what's happening in my country. Here we have some scarcity of neurosurgeons, and the emphasis is on physical care. People downplay the importance of behavioral care, which is very, very important in patients' holistic care. So all I have is appreciation. Thank you so much for the presentation.
Okay, thank you very much.
Working on a system to get to where the world is. Thank you so much.
Very much. So Lynne, maybe you can go to Africa. I think you can help. Thanks. Thanks so much. So we move to the next speaker is Prof.Virendra Sinha, please. So his talk today is outcome in pediatric traumatic brain injury. So what AI has to offer, please.
So first, I want to thank Professor Yoko Kato for providing this important platform for my presentation, and I'm happy to see number of friends here. So my topic is outcome in pediatric traumatic injury and what is role of AI. We know head injury to a child related by parents and family. Each child suffering from TBI is a trauma to child as well as family, and each has different level of severity. Till now, CS glaucoma score to assess the severity of child with pupillary changes. However, in children, and the response and verbal communication in young children is difficult, which do not facilitate accurate assessment. So CT scan helps to identify the deformities, structural deformities, and with regulation, the answer of the assessment. When child comes to emergency, there are worries and queries by the family members. Is the child safe? Anything to worry? Will he come out well? CT scan necessary? Or how my child will behave after this? Or we need a doctor urgently or not? So all the answers now given by NICE and CASE rules, Canadian guidelines. So these are the NICE and these are Canadian guidelines which tells us about the assessment of the prognostic factors in the children. In imaging, generally indicators to predict the outcome are intercerebral hemorrhage, SAH, basic systems where they're open or deformed, and with invasive laboratory investigation like glucose and hemoglobin, there is substantial improvement in the accuracy about the assessment of this type of the patient. What is more disheartening now, outcome may be good with a better clinical scale. Prognosis explained for 15 by 15 patient may lead to be a bad outcome. Nowadays, there is a strong emotional attachment to the families, the children. So blame there on the neurosurgeon, neurologist about the improper treatment, clashes between the medical teams, which are increasing in our country also. There were also already in the Western countries, lawsuits, and one tend to keep prognosis guarded always in pediatric groups. How to teach our residents about the prognostic factor, how to satisfy the family members in the emergency about the prognosis of the children. So specific models were given, like the impact, Helsinki score, Rotterdam CT score system, and Marshall classification in the CT scan. Mekonen is also a scale which is for adults, but it also works for the pediatric age group. This is the Marshall CT classification. This is the Rotterdam. This is the Helsinki CT classification from prognostic factor. And this is just a comparison of all. Nowadays, the Stockholm CT classification has come, included the diffuse axonal injury for prognostic factor also. If we see individually this scoring system, Marshall scoring system composed of the presence of mass lesion, midline, and shift of the system and effacement of the system. But the big problem in this is assessment or accuracy of the measurement of these mass lesions. When Rotterdam system came, the SCH was included in the system, but the limitation was not to differentiate between the type and size of the mass lesion. Then Helsinki came, in which the EDH was given -3, which is always positive in other health systems of the CT prognostic factor. Diffuse axonal injury, as I told before, in Stockholm, the CT score system was added, which helped about the better outcome prediction of the patient. We know that blood parameters, glucose and hemoglobin definitely helps better prognostic factor. Traumatic brain injury, we know, cause a lot of disabilities, morbidities, and social loss of the developing countries. And prognostication and early prediction of outcome definitely help in judicious allocation of the resources. Paragonker studied all the prognostic factor in 157 patients and found that Helsinki is the best prognostic predictor to assess the outcome of the pediatric patients. In low and middle income countries, Roderick studies 47 patients with all taking all these predictor about the prognostic factor, and he also found that Marshall CT classification was the least accurate model, and Rotterdam and Helsinki was the most accurate model for assessment of the pediatric patients. Nowadays, there is a lot of progress in medical, but at the same time, compensation and medical negligence is a lot there, and a lot of the practitioners are facing problem about the compensations. Medical professional, we know, losing its aura and sensitivity with rising cases of malpractice and negligence. And generally, we see on internet such type of ads that contact brain injury lawyer to suit against the negligence in the TBI cases. So nothing complete to exploitation in neurosurgery to prognostication. So we decided to propose or to develop a machine learning model to know the outcome of patient of TBI, which outperform existing CT classification system. For this, we use the AI or artificial intelligence in pediatric patient with TBI, which helps in prognosis of the patient and decision making as well. So I know that all of you know what is the AI. Just I will go through very small basics of this AI. What is AI? AI is the ability of machine and system to perform tasks that typically require human intelligence. So nothing is more than human intelligence. A computer AI also work on the human intelligence. If we go to the history of AI, AI was first coined by John McCarthy in 1956 in Dartmouth Conference. So this is the birth of AI. Birth of AI was in 1956 by John McCarthy. So, but the basic concept of of neural network is there is input of the data in form of the nodes. These nodes, they give the output of the in form of the results. So between these hidden layers are there. They interact in form of the weights. They are these lines. They are known as weights. These weights work and interact and give the result after the interaction. This is the basic concept of the AI. Now, just for example, suppose this is the cat face. If this is input can be trillions, billions. There can be more the input, better the output, or better the results of the any study. So this is the layer over the nodes I told. There is the hidden layer which we don't see, and the value can be -1 to 1. -1 means they are not important things which are interacting. If weight size is 1, it means that carries lot of weight, means meaning to interpretation of the findings. So just see this activation of the nodes. After input, this weight, they get activation of the hidden layer nodes, and this node is not activated. These 3 nodes are activated, so they are known as activated nodes. Then they further work, further interact, and they give the final result that this is the cat. Sometimes there can be wrong interpretation by the computer. Suppose it says dog. When it says gives wrong interpretation, then weight size, the reduction in the weight, so it go backward propagation. The logarithm move in the backward propagation. So weight reduce, and it say you have to correct this interpretation. Then in hidden layers, they interact further and they act further, and they finally, after correction, correct and give the good result. So it all depends on the input of the any data. More than better the outcome of the results are there. So this is another example. This is our different faces. The cat and dogs, and there are so many faces are there. So this inform the input layer, the hidden layer work, and they finally give predict whether it is a dog or cat. So in neural network, there are 2 parts. One is training part, other is the validation set. Good training part are very important, because the more data are included in the training part, if in validation we don't require, we just give the data, it will give the result. So training is very important part of the any AI system. This is the uses of healthcare and life sciences, the uses of AI in monitoring, asset, and like this. But I am not going to in the detail because it will take a lot of time. In my opinion, AI is an emerging stethoscope of coming time in medicine. So we calculated in our study, just I will coming to my study, we have in our GCS, CT score system, blood parameter, traditional statistical models. And why we opt AI? Why we opt AI? Because AI can provide very strong predictive despite of relative low number of poor outcome. It robustly predict binary outcome. Binary is either 0 or 1, yes or no. AI models can be trained and redefined, because if it is wrong, then with backward propagation, it will correct the data and outcome of the results. And can be trained on new patient information. And AI benefit from internal validation and testing, and the traditional statistical model studies, they have lot of inflexibility, and inability to change based on their data. But in AI, it can change as per the input. So finally, AI can predict outcome using binary and continuous variations, allowing a real-time clinical utilization. So we, in our center, we did a study for 2 years. We selected the patient of TBI below 18 year of the age. So what we were having in our study, GCS of the patient, blood glucose level, hemoglobin level, in CT scan finding, hemorrhage, midline shift, distal integrity, hematoma, skull fractures, and follow-up the patient was done up to the 6 months. And outcome was calculated by GUS score. All the CT scan classification which I showed before for prognostic purpose, we also included the Marshall, Helsinki, and Rotterdam. Patient was operated or treated conjunctively, but also taken in our study. So this is the GUS system for outcome of the patient. So we had 200 patients in our study, and average age was 8 years, and unfavorable and favorable we did up to 6 month follow-up, and unfavorable outcome was designated the patient whose GUS was less than. All the AI data which we have now for training purpose and validation, as I told, AI has a two-part, training and validation. So in our study, we had 50% training and 50% validation, 100 and 100 both the side, right? Then we use the AUC, area under curve, to know the accuracy of our results. And in our study, we have 16 input were put inside the study for know the outcome of our results. So there are the few inputs, GCSE scale of the patient, and pupillary changes, then systems condition, whether obliterated or compressed or normal, fractures whether linear or depressed, patient were operated or not. These are the, as I told, the various CT scoring classification we included in our study, and these are the general analysis of our patient. Now, in our study, what we found that 172 patients had a favorable prognosis. A favorable prognosis GCS was 12 with average of 12, and in this favorable patient or patient who had a favorable outcome, 2 patients had anisocoria, 4 patients had IVH, 1 patient had SAH, and 1 patient had obliterative cistern, and 6 patients had midline shift more than 5 millimeter. The depressed fracture has a better prognosis compared to the linear fracture. 28 patients had unfavorable prognosis, and average GCS was 5.6, and in this, most of the patient has unfavorable prognostic factor like anisocoria, INR was deranged, 7 patients had anisocoria, more patients were having midline shift, and linear fracture was more number of the cases were having 13 in our patient. So just I want to share a few of my patients we operated or we included in our study. This patient had an unfavorable outcome because hemoglobin was less, INR was more, and patient has a multiple contusion, basal systems were not well seen. This is another patient, although the CT looks good, but patient had unfavorable outcome because of the anisocoria, hemoglobin, this patient was intubated, and the patient was having facial bone fractures. Associated morbid conditions were there. This patient again had a unfavorable outcome as patient was anemic and patient just see having multiple. In fact, basal systems are not well seen, and so this patient also not had a good prognostic outcome. This is another patient, although here the CT looks very bad, lot of hematoma, but this patient was operated and patient was having an isocoria, but patient operated. So finally the ICP of the patient lowered down and patient was discharged without neurological deficit. This other patient had a good favorable outcome. Patient was having very high ICP, but this cerebral hematoma was removed and the patient improved the study. So when we calculated the result, as I mentioned, we took the AUC, area under curve pattern on the AI. So we found our accuracy was 0.93%. And so this blue line showing the training data patients, and orange line showing the who were taken for the validation study. So when we compared with the other this in the literature, we found by Penny and Frost who conducted the study, but he was included only patient who underwent surgery. Our AUC was quite good because maximum AUC, we had rigorous selection of input variables and lot of data we included. Then Shin et al. Used only the inpatient data, and so as I mentioned before, we had taken lot of data, including the CT scans, all the scoring system, patient gender, GS, patient operated or not, and CT scan. So that made our results very accurate and good results. And this is study we also doing for our other neurosurgical problem like lumbar degenerative disorder, and that toolkit also been developed. With this study in our hand, we can predict the outcomes of patient. Clinician can now do the immediately planned follow-up of the patient and early intervention. Patient as per the purpose of litigation, which is increasing day by day, thus we can use them, but misuse of litigation remain a matter of concern. So every study has limits, single center study, and we have not used the real-time change data. Like after surgery, patient develops pneumonia or secondary some comorbidities or complication, we have not included. They are all data we take from the emergency only. So what is the power of ANN? Power of ANN is large number of variables handled computationally, allowing for greater discrimination and resolution for outcome predictors. Then in future, we can utilize this model and it influence on clinical decision making, and we can compare the results by old statistical system and ANN, and we can see which is better. So this will help in future also. So ANN is like a black box where user provide input data and receives a prediction, often without understanding how the prediction is being generated. So this is our, as I mentioned, this is a lumbar canal stenosis toolkit, which already we have downloaded. It is on the Google site. And just I want to conclude that AN is a promised a future with a near accurate AI-based prediction of prognosis among the pediatric TBI for the help to the clinician in taking decision as well as counseling the attendants. So thank Thank you very much. And shortly, we will have this toolkits of our pediatric AI also, and which help. Yeah. Thank you very much.
Thank you, Dr. Sinha. So I think it was really interesting because of the AI supports the neural network, or especially the younger the trauma patients. So I can take one question, and also maybe first a comment from Petra.
Thank you, Sensei. Perhaps, Professor, what I want to ask is how does this prediction model perform? You gave us two cases which seem to be an outlier, the one with the good CT scan but the bad outcome, and the one with the horrible CT scan, but he was discharged with no neurological deficit. Did your model, can it currently predict that this patient will have a good outcome or bad outcome? What do you think, Professor?
Yes, this is a part of our case study only. So in emergency, we could know this patient will be operated and timely. So the trauma and operating time was very less. So we took everything in consideration in our study.
Thank you, Professor. I think with the time and more training, your model will become more excellent.
Yeah, thank you.
Thanks so much. So the parts from India.
Yeah, good afternoon, everyone. Thank you for the very good lecture on AI, Professor Sinha. I'm from Bombay Hospital, Mumbai. So my question was, is there commercially available free tool as of now on the internet which we can use for predicting the similar thing like outcome in the patient? Yeah, that's what I wanted to ask.
Yes. Because there are only very few studies are there to predict the neurosurgical problems.
Okay.
As I mentioned, we have our toolkit on internet is available for the degenerative diseases in the lumbar spine. So you can check this toolkit on Google and you can use it for your patient also. So whatever new studies are coming, they are making the toolkits and they are available on the net, and we can use them for our patient. No problem.
Okay. Thank you. Thank you so much.
Okay, thank you. Thanks so much. I think it's time of the AI or deep learning time. So I think you can research more and please reflect to the the younger generation. Thank you very much. I really impressed your lecture. Thank you very much.
Thank you.
As always. Thanks so much. So we proceed. The next one is Professor Atsuhiro Nakagawa Sensei from Tohoku University. He is one of the top trauma neurosurgeon. His talk is understanding the pathophysiology to improve care or TBI management, please.
Thank you very much, Professor Kato. Can you hear me?
Yes.
Okay, thank you. Hello, this is Atsuhiro Nakagawa, and I'm neurosurgeon at Tohoku University in Sendai. I'm also in charge of Alliance Office and directing co-creation with industries, roughly about 100 companies per year, including multinationality companies, data science company, AI company, to improve patient care and redefine the role of academic hospital, not only the diagnosis and treatment, but creating new innovation by solving problems with the industries and academic researchers. Again, I would like to express my deepest gratitude to Professor Yoko Kato and support from Dr. Boon-Sen Liu for this opportunity. Today, I would like to express importance of understanding pathophysiology and get back to original article in the past, rather than just following the instruction in the guideline to improve care of TBI management. So this is where we currently stand regarding severe head injuries. According to systematic review by Dr. Stein, summarizing the mortality rate of severe head injuries since 1880, the mortality rate, which was nearly 70% for 50 years from 1880 to 1930, has decreased by an average of 3% per year. The author mentioned that the main factor for that changes was due to decrease in malpractice. From 1930 to 1970, there were great advances in intensive care, including antibiotics and respiratory equipment. But with the advent of high-energy trauma due to the spread of automobiles, these two were offset and no improvement in mortality rate was observed. From 1970 to 1990s, there was significant improvement at an average of 9% per year. Imaging modalities such as CT, intensive treatment using monitoring, wider and deeper understanding of pathophysiology, along with law and industrial preventive measures contributed to these significant changes. Then, what about the current situation? Although attempt has been made to standardize the treatment and introduce new technologies such as data science, they have not been able to sufficiently overcome the impact of changes in the traumatic structure of the super aging society, as we are suffering in Japan. As a result, there are no significant improvement during the past 30 years. The essence of neurointensive treatment is how to control secondary injury. When a primary injury occurs by head injury, the brain is unable to withstand secondary insults such as hypoxia and hypotension, which are normally tolerated due to disorders in the brain autoregulation, resulting in secondary injury, and this will end up in worse outcomes. However, it has been reported that secondary insult is not fully controlled. John et al. From Edinburgh reported that secondary insult was observed in 91% of the cases during the ICU stay. Guidelines for the treatment and management of severe TBI have gone through 4 editions in the past 30 years since the first edition. Standards the treatment with the main aim of preventing secondary injury. Although great progress has been made during the past 30 years in efforts to avoid primary insult and injury, such as legal regulation against drunk driving, which has been successful in Japan, and the introduction of a technology including automatic collision avoidance system. There are no methods, including drugs, that have been shown to be effective for prevention of secondary injury and improving outcome. When managing intracranial pressure, ICP, and cerebral perfusion pressure, CPP, it is essential to understand the brain autoregulation. Cerebral autoregulation is a control mechanism that maintains cerebral blood flow, CVF, approximately constant within certain pressure range, which corresponds to a CPP value of 50 to 150 millimeter mercury. The vascular bed, which is a resistant blood vessel, adjusts CVF by changing the vascular diameter, changing the cerebral vascular resistance, CVR, in response to changes in CPP. This is self-protecting mechanism to prevent capillary damage, edema, diffuse bleeding, and increased ICP. It has been reported that in 40 to 71% of the severe TBI, cerebral autoregulation is abnormal, disturbed, and changes over time. Today, we will discuss 5 statements in the BTF guideline along with the pathophysiology and landmark articles. First, cerebral perfusion pressure monitoring and thresholds. There are several statements, including many 60 or 70 numbers, but have you ever considered what those numbers and where these evidence came from? I'd like to explain from pathophysiology today. There are a series of challenges struggle for CP management in the past, but understanding of autoregulation is the first step to understand this deeply. When cerebral autoregulation is maintained and within the range of regulation, the upper right vasodilatory cascade, probably first reported by Dr. Rosner in 1980s, functions to counter the decline in CPP, and the vascular bed compensatory expands and up in increased cerebral blood volume, CVV, and ICP. Conversely, when CPP increases, the vascular bed contracts due to the vasoconstriction cascade in the lower, as shown in the lower right, and end up in decreased CVV and ICP. The state in which mechanism is functioning is called pressure active, and the CBS maintain constant as shown in the solid line. On the other hand, if Suehiro of autoregulation is impaired, ICP changes in accordance with the changes in CPP, and CBF also changes linearly in accordance with CPP. This is why we need to care about the pressure. This state is called pressure passive state. Second topic is cerebral fluid drainage. This is a pressure volume curve that shows the relationship between intracranial volume and ICP. In the regions shown from A to B, where the decrease in intracranial compliance is mild and there is sufficient buffer reserve remaining, the changes in ICP is mild, and with respect to the increase in the intracranial volume. On the other hand, beyond the breakpoint shown by B, in the region shown from B to C, where the intracranial compliance is significantly reduced and buffer reserve is reduced, ICP increase become exponential for a small, even for a small increase in intracranial volume. Understanding of intracranial compliance will help you to understand the importance of even a small amount of cerebral fluid drainage can be expected to reduce ICP dramatically, especially if the patient is in the area transitioning from B to C. Third, decompressive craniectomy. According to a joint study by Germany and United States regarding appropriate size of the craniectomy area after middle cerebral artery occlusion, theoretical analysis revealed that shear stress and torsion occur due to small craniectomy area after craniectomy. Together with damage to bridging veins, it has been suggested that this may lead to worse outcomes. Another study from Heidelberg University, showing the figures on the lower right, shows that additional volume that can be obtained with a craniectomy range of 12 centimeters in diameter is equivalent to 100 cubic centimeters, and by increasing this to 15 centimeters, the additional volume becomes 200 cubic centimeters, which is sufficient. So this is the reason for these numbers. The figure on the lower left shows the result of study from UK using the index indirectly reflects the brain autoregulation ability and suggests that providing a sufficient craniectomy range increases the brain's buffering capacities. Next is ventilation therapies. Partial pressure of arterial carbon dioxide is also an important factor in cerebrovascular resistance, CVR, through pH changes, and it is thought to change CVF almost linearly. Many studies have conducted, including the RCT reported by Mitsera in the early 1990s. But currently, as stated in the guidelines, prolonged prophylactic hyperventilation with partial pressure of carbon dioxide in arterial pressure, but a PaCO2 of 25 millimeter mercury or less is not recommended, because you can easily imagine that the calibers and decrease of CBF according to the decrease of PaCO2 on the left figures. By understanding the underlying pathophysiologies, we believed that you will gain more practical knowledge that you can incorporate into for the better patient treatment. Hypoosmolar therapy. In these issues, I would like to stress the importance of getting back to the original articles, landmark articles by the past colleagues, great colleagues in the past. So how is these numbers decided, for example? So these are not maybe Japanese written, so international norm, but very good articles that I would like to introduce today. In 1960s, mannitol, which was used to measure renal glomerular filtration, had a lowering effect on intracranial pressure, and later glycerol, which is limited use in Japan, were also reported to have lowering effect on intracranial pressure in animal experiments. Around the same time, measurement of continuous cerebral spinal pressure became available. Technology became available, and many clinical studies were conducted on intracranial pressure lowering effect of the drug and its administration time, as well as on the control of rebound phenomenon. Current BTF guidelines state that although hyperosmolar therapy may lower intracranial pressure, there was insufficient evidence about effect on clinical outcome to support a specific recommendation or to support use of any specific osmolar agent for patients with severe traumatic injury. But this historical study may give us insight for utilizing new technology. When this was the case when I was joining informatics project at clinical neurotrauma clinical fellowship at UCSF, and now expanding work with numerous data science company back in Sendai right now. Again, I would like to emphasize here that no improvement can be achieved without understanding of the pathophysiology and the landmark work passed by the past legendary colleague, even with most cutting technologies. So finally, intracranial pressure monitoring. Unfortunately, we are not be able to show the benefit and advantages of using this monitoring in the meeting demanded by the society right now. But finally, I would like to emphasize the importance of understanding pathophysiologies and landmark work by the colleagues in the past. It is for the ICP, it is possible to obtain a lot of information about the intracranial control process from ICP waveform analysis. The measurement of cerebral spinal fluid pressure has been studied in experimental animals since the late 1930s, and measurement in clinical cases were reported in the 1950s, but measurements were only taken intermittently. Lundberg and colleagues developed a system that combines strain gauges and electrical signal amplifiers to continuously measure cerebral spinal fluid pressure and recorded it on paper and reported the data from 30 cases to Journal of Neurosurgery as a preliminary report. They classified the characteristic waves that appear when ICP increases into 3 types, like Lundberg A. The plateau wave is always pathological, increased by about 30 millimeter mercury with poor outcomes. Cerebral autoregulatory ability is generally maintained until the appearance of the wave, and it is thought that it appears due to stimulation such as increased ICP, decreased intracranial compliance, instability of cerebral arterial pressure, or slight vasodilatation. It is likely that computer science will be incorporated in the future efforts, since it has possibility to have solve so many problems, not only in Japan, but I have this will be concluding, part of the concluding slide, but not as so much, maybe 1% of the Professor Kato, but I have, I'm working as a funding agency in the Japanese government for bringing out Japanese technology to oversee and emerging places, and such as India and also Vietnam, and also Indonesia, and recently I went to Kenya and many other places. Of course, I did a training in San Francisco where they have the cutting edge technology here. But as far as we talk about Japan, our population is decreasing. And how to maintain the standards of care is becoming difficult due to many reasons. So like we are doing today, having the opportunity to from the expert and learning about the guidelines and standards, of course, utmost importance. But also improvement of technology may help to underscore those future programs. And the final message for today is to maintain the daily practice and also to develop future technology to keep our high quality cares and sustainability in a sustainable fashion. Maybe it is important to understand pathophysiology along with knowing much about learning from the past is very important. Thank you very much.
Thank you very much, Nakagawa Sensei. So you went so many places, especially the low middle income the countries.
And 1% of Professor Kato.
No. Thanks so much. So I think that your final remark is maybe in the future, everywhere in the world can have the same, the equal result, I think. So take a question, a comment. Petra?
Thank you, Sensei. I think it's very interesting because the first presentation we had this afternoon is about the new guidelines for the traumatic brain injury. And I think there is a very big difference between the guideline that you use in a battle situation, like, for example, in the first lecture. And perhaps in Japan, it will be more on motor accident and falls. And I think it will be very interesting to see a sub-guideline, perhaps, to address senior population and lower force trauma and how we can improve the outcomes in these patients. And I think Nakagawa Sensei will be a very good place to start with that kind of guideline. Thank you, Sensei.
Thank you very much, Petra Sensei. I think this will be more suitable topic, described by Professor Suehiro. But we are also conducting the, population studies in Miyagi Prefecture, which has 2 million population and started about 30 years ago. And we had two, peak for the population, younger peak and maybe 65 years old was second peak. But right after 2010, the first peak in the young age was totally lost. And we have a highest peak in the maybe 80 years old in Miyagi Prefecture. And as you can easily imagine, the trauma mechanism has totally been, changed to fall instead of from, a motor traffic accident. So, but I think, we can have a lot of, insights, not only by our keen observation, by having a database. And we are now trying to build up, huge database as a kind of remedy of the large earthquake we had in 2011. And it covers 83% of the total bed of the Miyagi Prefecture, working with the industries and the government. So maybe not directly to your answering your question, but we also would like to solve many programs for the aging societies and share to rest of the world. So I hope we can work with you on that topic as well in the future. Thank you very much.
Okay, thanks. Lynne, do you have any question or comment for him? Dr. Lynne?
Hello. Yes,
Hello.
I would like to congratulate Professor Nakagawa on that lecture, highlighting the way that we should be looking at not just the ones that the guidelines, but of course the guidelines has already been based on also examining the pathophysiology of how this the secondary injury will affect more the patients. And I hope one of these days we can share, and of course we will invite you guys in our neurotrauma bootcamp. You can share this knowledge to all the other not just neurosurgeons but other specialties, so that they will be able to appreciate more the way that we should control the hypoxia, we should prevent hypoglycemia, all those things, how it will affect the status of the patient later. Thank you so much.
Thank you very much. Hope we can work together in the future. Thank you very much.
So this was from Bangladesh.
Thank you, Sensei. Trauma is very interesting topic and very controversial. Just two questions. In the general management, what is your actual protocol for mannitol or 3% sodium chloride? And
Excuse
for
me?
specific, for the general management of the trauma patient, if you have to reduce the ICP, apart from the ICP monitoring, is there any protocol you practice with the 3% sodium chloride or mannitol? This is
Yeah,
number
we are
one.
using mannitol, and it's Japanese guideline is following the evidence, including BTF and other evidence from the world. But I think, between the line, between the sentences, what sometimes matters. And also, what we did in San Francisco General Hospital was quality management by the nurse practitioners. So I think how much % of the compliance rate is achieved, and how much is it, following the number is sometimes, or I don't want to say always, but sometimes, kind of there is discrepancy. So I think quality assurance is also a very important part of what you have said.
Oh, okay. Another one is for the specific management. I mean the decompressive craniectomy or called the door craniotomy. I mean the keeping the bones in two part, which is called the hinge craniotomy. And another one is the recent term sternostomy. Any experience between comparing all these three techniques?
Actually, Japanese neurosurgeon tend to insert the ICP monitoring in the interpreculum way instead of inserting into the ventricles, which we should insert into the ventricle. That is some kind of I think. Dr. Sehi, if you would have some information to add, please. But I think to compare is very important. But maybe one of the problems in Japan is trauma center is scattered, so, and data platform is not difficult to share. So I think it is like what the Jeff Manny and other leaders is doing globally is very important, and we need to compare for better management. But it is difficult to do that. So do you have anything to add, Dr. Suehiro? But I think that's a current situation. But thank you very much for the question.
Oh, okay. Thank you.
Okay,
Thank you.
Thank you so much. Hi, Nakagawa Sensei. All the best for your future the research. Thank you so much.
ありがとうございました。
Hi. So we move to the next speaker. The pleasure to invite the Professor Peter Hutchinson.
すいません。
So he is a great trauma neurosurgeon. Everybody knows, of course. Very honored to have you. Thank you very much. So his talk is rescuing the injured brain. Very attractive. Thank you very much.
Good afternoon, everybody. Thank you, Professor Kato, for the very kind invitation. I will just share the screen. There, does that share okay?
Yeah, thanks.
Yeah, anyway, thank you very much and for the invitation to speak at this webinar. So I'm going to spend the next 15 minutes touching on some aspects of traumatic brain injury. If you look broadly speaking, and everybody's familiar with this, traumatic brain injuries fall into two main types. There are those that need urgent surgical intervention, such as space-occupying hematomas, like this acute subdural hematoma. But many of the patients that we see do not have a neurosurgical space-occupying lesion, but they have issues with a diffuse brain injury, swelling and coma, and need management on intensive care. Broadly speaking, the management of these patients relates to the control of brain swelling, and as we've heard in the previous lecture, the issues in relation to raised intracranial pressure with the impact on cerebral blood flow, failure of oxygen delivery, energy failure, further cell death and swelling, which culminates in poor outcome for the patient. So the goal of management is to intercept this cycle. The brain has an amazing ability to maintain its cerebral blood flow across a very wide range of blood pressure from 50 to 160 millimeters mean, and this is the classic autoregulation curve as described by Lassen in 1959. So there's this long plateau and the brain can accommodate wide fluctuations in blood pressure. But the problem with traumatic brain injury is that this autoregulation is often impaired, and the consequence of that is that a fall in blood pressure will affect cerebral blood flow. And with my colleagues in Cambridge, Professor Chosnica and Chmielewski, we are now able to model this response of autoregulation using the PRX index, where we look at the relationship between the changes in blood pressure and intracranial pressure. And you can see there are some instances when the blood pressure goes up, the ICP goes up, and some instances when the blood pressure goes up and the ICP goes down. And this can now be defined using computerized bedside monitoring. This is the ICM Plus software, where we can see periods of dysautoregulation in red along the bottom here and green when the patient is autoregulating. And this is now impacting on the way we manage these patients. So the current algorithm for the management of patients on the intensive care unit is to maintain a target of the ICP of less than 25 and a cerebral perfusion pressure of greater than 60 using these 5 stages of therapy. So anesthetic sedation, stage 1, nursing head up, careful control of the blood gases. Like we've heard previously, we don't put in a ventriculostomy at the beginning, but that is an option to try and control ICP by CSF drainage at stage 2. Inotropes are quite a powerful weapon in terms of controlling ICP, but they will only work if the brain is autoregulating. So I think this is where this autoregulation is important, because if the brain is autoregulating by increasing the blood pressure using inotropes, then we can lower the ICP. The use of hypertonic saline versus mannitol is controversial, and we're currently conducting an RCT comparing these two therapies. We have a particular interest in the 15% of patients whose ICP is not controlled by standard medical interventions, and these patients have ICP above 25 despite medical treatment, and in those there are various options, a barbiturate coma or a decompressive craniectomy. So how do we tie this all together? So the routine approach that we put in Cambridge now is to insert a triple lumen access device, and we place through this single device 3 monitors: an intracranial pressure monitor, standard of care, a brain tissue oxygen monitor, and there's increasing interest in the use of that technology to monitor for cerebral hypoxia. And then this technique of cerebral microdialysis that measures the brain chemistry, and particularly how glucose is delivered to the brain and how it is metabolized by glycolysis to pyruvate, enters the citric acid cycle, which is where ATP is generated. Now, under adverse circumstances following injury, either if there is failure of oxygen delivery or mitochondrial dysfunction, then pyruvate is preferentially metabolized to lactate, and this lactate pyruvate ratio is a marker of anaerobic metabolism. So we've now, using the triple bolt monitoring of ICP, oxygen, and microdialysis, looked at large numbers of patients and the trends of outcome, particularly with the lactate pyruvate ratio. And what we can begin to do now is manage these patients beyond the simple concept of intracranial pressure, where we have a number of different insults. So we can have a low brain glucose, a low brain oxygen, a low cerebral perfusion pressure, or a state of dysautoregulation. And you can see for some of these patients, there may be one abnormality occurring at any one time, but for others, there may be multiple pathophysiological derangements. So we can now move towards a state of more precision medicine for managing these patients, where we have this characteristic signature based on the brain chemistry, pressure, and oxygen to define a neurometabolic state. And we can address the therapy specifically. Is this purely raised pressure? Is it a failure of oxygen delivery, a failure of glucose delivery? And then there is this concept that when we are delivering enough oxygen, glucose, and the pressure is controlled, energy may still fail because of mitochondrial dysfunction. So this is an algorithm that we're currently piloting, where we start by looking at the intracranial pressure. If it's greater than 20, then we would target ICP protocol management. If the brain oxygen is low, we can increase it, starting by increasing the cerebral perfusion pressure. If the glucose is low, we will actually now administer dextrose patients. And then we're looking at more novel approaches for mitochondrial dysfunction, including supplementation with disodium succinate. You'll be aware that over the last 2 or 3 decades, there's been many attempts at novel approaches to the management of patients with traumatic brain injury. And sadly, there has been no magic bullet of neuroprotection. The hypothermia trials have been disappointing. There are trials of other therapies. But an alternative approach, of course, is the surgical approach. And these are the common pathologies that we see in traumatic brain injury. So a traumatic intracerebral hematoma, diffuse brain injury, acute subdural hematomas, and chronic subdural hematomas. And the surgical indications for the management of these patients have not always been clearly defined. So what we've done is, with others, embarked on a series of randomized trials to try and address the indications for surgery according to a number of these different indications, notably diffuse brain injury, which was interrogated by the DECRA study and our study Rescue ICP, and more recently, the surgical approach to the management of acute subdural hematoma in the trial of Rescue Acute Subdural. So if we return to our algorithm, the challenge I think that we face is that in about 15% of patients, we get to this stage 5 of the raised pressure, not controlled, and there is a debate about the role of a decompressive craniectomy. So Rescue ICP sought to answer that question. I'll just briefly summarize the results because they've been presented and published previously, but I think what's quite helpful is just to look at how we can digest these results in the real world and try and use them to help improve the management of our patients. So you'll recall that these were patients with a traumatic brain injury, ICP above 25, who were randomized between advanced medical management, including barbiturates in one arm, versus surgical management of decompressive craniectomy in the other. So recently, we've published the 24-month data from this trial. So this is the outcomes according to the 8-point Glasgow outcome score at 6 months in the surgical group and the medical group. And you can see this marked difference in mortality, a much greater mortality in those managed medically with barbiturates compared to surgery, but a wide range of outcome distribution in the survivors. But I think what's really helpful is to look at this differently, in that if we just dissect out the surgical patients, what we're beginning to see is that there's no doubt that these patients who've had a decompressive craniectomy improve with time. Classically, we've looked at 6-month outcomes for Glasgow outcome score patients following TBI, but this is the cutoff between moderate and severe disability, and you can see this progression of improvement in these patients between 6, 12, and 24 months. So this is, I think, somewhat more encouraging for the role of decompressive craniectomy. So how can we use these results? I think one of the concerns is that decompressive craniectomy, we all know, in a proportion of patients leads to poor quality survival of vegetative state and very low severe disabilities. One of the theories that we have is that some of these patients may have a pathology that defines their prognosis, which is not helped by a decompressive craniectomy. And this pathology includes brainstem injury, with brainstem injuries not being controlled by craniectomy. And brainstem injury is often not diagnosed on a CT scan. So we're beginning to advocate the role for an early MRI in these patients in order to refine the decision making. So Rescue ICP shows class 1 evidence that decompressive craniectomy is life-saving, that is beyond doubt. At 24 months, those who underwent it continue to improve. And in terms of discussing with colleagues and families what the outcome from this procedure is, in essence, if you undertake a decompressive craniectomy in 100 patients whose intracranial pressure is more than 25, then you will save 21 more lives. So that's quite a significant number of survivors. Of those survivors, they break down into thirds. About a third will be dependent on care. About a third will be independent at home, able to manage themselves, but about 1/3 will now be independent outside the home. So I think it's better to avoid terms such as favorable or unfavorable, because what is favorable for one family may not be favorable for another, and better just to state what the evidence shows. That as a rescue intervention, decompressive craniectomy reduces mortality. About a third of the survivors are dependent. About 2/3 are independent. We need to do more to work out how we improve this ratio further. Finally, I just want to mention the rescue acute subdural trial. So this was the follow-on trial from Rescue ICP. Rescue ICP focused on diffuse brain injury. The rescue acute subdural focused on acute subdural hematoma and sought to answer a very simple surgical question. Do you put the bone flap back, or do you leave the bone flap out and undertake a decompressive craniectomy? So this was decompressive craniectomy versus craniotomy for acute subdural hematoma. Does decompressive craniectomy lead to better functional outcomes compared to craniotomy for adult head injury patients undergoing evacuation of an acute subdural? So patients undergoing surgery were randomized to bone back or bone off. The sample size was 440 on a number needed to treat basis of 7, and the primary outcome was the extended Glasgow outcome scale at 12 months, with the secondary outcomes the same scale at 6 months and a quality of life measure. So this trial was a challenge because the patients were actually randomized in the middle of the operation. They were consented preoperatively, taken to the operating room. The scalp flap was raised, the bone was taken out, the dura was opened, and the acute subdural hematoma was then evacuated. Following evacuation of the acute subdural hematoma, patients were randomized to having the bone flap put back or the bone flap left out, i.e. a decompressive craniectomy. Of the patients randomized, they were included in the analysis. There were a number of patients in what we call the observational cohort when the brain was so swollen following evacuation of the hematoma, it was not possible to replace the bone flap. So these patients were followed separately in the observational cohort. So in essence, what we did then was we took these patients, we randomized them when we could to bone out or bone back. In the end, we randomized 462 patients. This was an international effort, and we're really grateful to the investigators, and many of the investigations were in Asia, so we're very grateful for that. The baseline characteristics of those randomized to craniotomy versus decompressive craniectomy were all well matched. You can see there the mean age was 48, as with all TBI studies, predominantly male. And in summary, these were the results. The median bone flap diameter was the same at 13 centimeters, whether the bone was put back or left out. If you look at the 12-month outcomes, there was no significant difference in the GOS ratings across the outcomes: mortality, vegetative state, severe moderate disability, and good recovery, whether the patient had a decompressive craniectomy or a craniotomy. The same applied to the quality of life survival. Now, this is important, additional cranial surgery within 2 weeks. So what do we mean by that? What we mean is, were patients taken back to have the bone flap subsequently removed when it had been replaced? An additional cranial surgery did occur in 28 patients undergoing a craniotomy, but that was actually relatively rare. 18 of those 28 had a decompressive craniectomy, but the actual number of patients taken back for a decompressive craniectomy, having originally had the bone flap placed back, was low, and there were more wound complications in those who'd had a primary decompressive craniectomy. So these are the results. Show graphically there was no statistical difference in the Glasgow outcome at 12 months. So we can conclude that among patients with traumatic acute subdural hematoma who underwent decompressive craniectomy or craniotomy, disability and quality of life outcomes were similar with the two approaches. Additional surgery was performed in a high proportion of the craniotomy bone back group, but relatively few patients underwent that, and there were more complications in the craniectomy group. So how can we use the results of rescue acute subdural to help manage our patients and influence our practice decisions? So we feel that if the bone flap can be replaced without compressing the brain, once you've taken out an acute subdural hematoma, you should consider doing that as opposed to performing a preemptive decompressive craniectomy. So put the bone flap back if you can. But there is the caveat that these patients were managed on an intensive care unit post-operatively, where ICP could be controlled medically. So it's important to note that these findings may not be relevant for resource-limited or military settings where preemptive craniectomy is often used and appropriately used due to the absence of advanced ICU facilities for post-operative care. I think it's also important to point out that the rescue ICP and rescue acute subdural trials were predominantly performed in high-income countries. And during the decompressive craniectomy consensus meeting, we had a separate section on a consensus concerning decompressive craniectomy in low and middle-income countries. And there is increasing interest in this operation. This is a compromise between craniectomy and craniotomy. This is the hinge procedure where the bone is replaced but left hinged to accommodate brain swelling. The advantage is that the brain can swell under the lifting bone, and the other advantage is that you do not have to undertake a subsequent cranioplasty. And this is an operation that we're currently trialing with colleagues in India. And we have undertaken this procedure now in Cambridge, also on a number of occasions. So to finish, rescuing the injured brain. Multimodality monitoring increases the understanding of the pathophysiology of TBI, autoregulation, pressure control, oxygen and chemistry to help guide ICU management. We all know that a large traumatic hematoma, extradural, subdural, should be evacuated before neurological deterioration develops. A large trauma craniotomy, so a big bone flap, is necessary to perform optimal damage control and provide the option for a decompressive craniectomy. So these patients should have a large trauma craniotomy. If the brain is very swollen at the time of that initial surgery, following evacuation of the hematoma, it's appropriate to leave the bone flap out. But importantly, in the absence of brain swelling, we feel that in the majority of patients, the bone flap can be safely replaced. They do not require a primary decompressive craniectomy. And I think rescue ICP and the 24-month results are now showing increasing numbers of patients that secondary decompressive craniectomy is effective in controlling ICP, and now with evidence for improvement in the long-term outcome. I'd like to acknowledge the participants in the rescue trials, their families, our collaborating investigators across the world, research staff, Cambridge and beyond, the steering committee, data monitoring committee, and particularly the UK National Institute for Health Research, who funded these trials, and the British neurosurgical trainees who've been fantastic, our residents in helping with recruitment. Many colleagues in Cambridge and beyond. And finally, I would like to invite you all to Cambridge to come to the International Neurotrauma Society meeting, Neurotrauma 2024, which will be held in Cambridge from the 31st of August to the 5th of September. The abstract deadline has been extended to next week, so please feel free to submit abstracts, and the early registration ends in May, and this is will direct you to the link neurotrauma2024.com, and it would be great to see as many friends as possible during that meeting. Thank you again for the invitation to speak at the webinar, and I'm really happy to answer any questions.
Thank you so much, Peter. So, what a nice talk, and especially the craniectomy and the replacement of bone. The statement is very, very important for basically low-income country. Maybe can I take Sharon from Malaysia?
Thank you, Prof. Kato. Prof. Hutchinson, a quick question, because we do a lot of decompressive craniectomies in Malaysia, all right, particularly. And like what you said, especially if noted if the patient is older, then the brain is not so swollen. But sometimes what happens is, maybe it's a component with diffuse brain injury. So sometimes when we don't put back the bone, patient tends to develop, if we do put back the bone, it tends to develop delayed edema. So what's your consensus on that?
Yeah, so as I said, that happened in 18 of the 28 patients who were the bone back. So there are a number of patients when you put the bone back who have pressure problems. So what we try and do with them is manage them medically. We can tide them over with the medical management of ICP, those conventional therapies, mild hyperventilation, osmotic therapies, and to try and control the ICP. But sometimes you have to go back and take the bone out. But it's a compromise between trying to spend a few days managing that patient medically compared to taking them back to the OR for what is 2 more operations, the bone out and then the cranioplasty. But as I said, it's important that you have access to facility that can control ICP medically. Otherwise, it probably is safer to leave the bone out. You also made a really important point about the elderly patient. So I think what's becoming clear is that acute subdurals in young people, with generally a higher impact injury, have underlying brain swelling, the burst temporal lobe, and those are more at risk of brain swelling. And what we're seeing now, probably the commonest cause of traumatic brain injury in the UK is the elderly patient who's on antiplatelets, on anticoagulants, has a pure acute subdural, minimal underlying brain injury, and those we're confident you can put the bone flat back safely. Yeah, that's a good question. Thank you.
Thank you. Thank you very much, Prof.
So the commissioners from Bangladesh.
Thank you, Sensei. Very interesting to see this presentation. Sensei, what is your radiological and clinical guideline to go for the hinge craniotomy? As you said, you have incorporated that in Cambridge. This is number 1.
Yeah.
And number 2, any experience with cysternostomy, especially in case of acute subdural with contusion?
Okay, so the hinge craniotomy work is predominantly directed. So with Tariq Khan, we have the NIHR global research group on acquired brain and spine injuries. So that's a number of RCTs. So we're predominantly performing hinge craniotomy in India at the moment. We have had a couple of patients in Cambridge where the brain was not swollen. We didn't want to put the bone back because we felt this was a case that would swell. And logistically for that patient, in terms of the logistics, it was going to be difficult to do a cranioplasty. So we did put this hinge craniotomy successfully in a couple of patients. But I think we need to be very wary of undertaking these procedures without the evidence. So we're reluctant to do too many of these outside a randomized trial, because otherwise I think you can fall into the same issues with decompressive craniectomy in the 1970s and 1980s. We have no direct experience of cystinostomy in Cambridge. I know there's increasing interest in that procedure, and my only appeal about that operation is that there's a number of observational studies that are great, but if we're going to do it again, I think it should be undertaken as an RCT properly designed with very careful assessment of the outcome. But it may well have a role. Thank you.
Thank you, Peter.
Thank you.
Dr. Petra?
Thank you, Dr. So, Professor Hutchinson, I think it's beautiful how you put in the conclusion for the rescue ICP study, because in the past, I've always told the patients the statistics from a neurosurgeon's point of view, this many will die, this many. I think it's beautiful the way you put it, in a way that they will understand. And I think I'll do that more in the future. I think that way of putting things is more acceptable to the layperson compared to the neurosurgeons. Thank you so much.
Okay. Yeah, I think rescue ICP people have quite strong views about what the results show, but my feeling about these trials is for us to produce data to provide the evidence, the numbers, for people then to make their own decisions and guide their own practice. Historically, we've talked about trials being positive or negative, favorable, unfavorable. I don't think these trials are like that. It's about providing data to help people with their own decision making, because culturally there's many differences in the world about how disability is perceived and what people will accept. So we know that many of our collaborators will accept quite a high degree of disability and be grateful for a life that is saved, whereas in other parts of the world that is not the case. So I think that there are many cultural and ethical issues beyond the scientific outputs.
Okay, thanks, Peter. So maybe Aniak from Nigeria. Unmute, please.
Yes. Yeah, thank you, Prof. Thank you, Professor Yukokato. Thank you, Professor Hutchinson, for the presentation. Yes, decompressive craniotomy as practiced in my country. Yeah, the hinged craniotomy, we'll call it floating craniotomy. Yes, and it's usually osteoplastic. We noticed that in patients, preoperatively in the imaging CT scan, usually there are some indices of marked brain swelling, and then there we prepare for craniectomy for cranioplasty later. Yes, sir. And this commonly seen in young patients. Marked brain swelling. When we have acute subdural hematoma, usually associated with parenchymal brain injury with marked brain swelling. So thank you so much for this presentation. It's a guide to what we're doing here. And this is very, very helpful. Your presentation is very, very helpful. Thank you so much, sir.
Yeah, no, thank you for coming. I mean, I think the other interesting concept about hinged craniotomy is we probably need to work a little bit more with the engineers about the benefit of removing the bone itself. I think we probably need to work out how much volume of cranial cavity is gained by removing the bone as well, because the bone itself, of course, will take volume. So although it's floating, it's still there. So I think we probably need to do a little bit more basic science research on the hinged craniotomy.
Thank you so much.
Thank you, Peter. So what a wonderful talk. So maybe we will invite you again, and thank you so much for your very informative.
Right. It's nice to see everybody, and thank you for accommodating me slightly later. It's 7 o'clock in the morning. It's a beautiful day, so it's nice to be up early. Thank you.
Sorry for the time. Thank you very much. Anyway,
not at all. It's absolutely it's a pleasure. Yeah.
Thanks so much. So we move to the next speaker, Dr. Tariq. No need to introduction. So today his talk is making traumatic brain injury notifiable condition. The Yahoo Mail, search and organize and conquer. Professor Tariq.
Thank you so much, Yoko, and thank you, team, for inviting me to this important meeting. Can you see the screen?
Yes.
Okay, so I'm going to talk about something which is if I may say, an evolving policy document, and of course would need your help, everybody's help to move it forward. So the idea basically started when we were in Cambridge for the NIHR program with Peter Hutchinson and myself and Professor Tony Figacci from Cape Town. We started discussing that how can we tell people how can we tell people about the number of patients, because we don't know how many neurotrauma patients are there, especially in the lower and middle income countries. And we thought about looking at it to see whether we can convert this into a notifiable condition. So these are the collaborators, myself, Professor Franco Savade, Walt Johnson, Tony Figacci, Professor Hutchinson, Gail Russo, Key Park, Asra Al-Fawzi, and Dr. Almas Khatak. And just to inform people who don't understand, what are the notifiable conditions? Presently, they are mostly infectious diseases and food-borne illnesses, and the public health surveillance is being carried out here. And existing systems for notifiable conditions, if you can see, are in very few countries across the world. And I believe that Australia is the only one which currently includes traumatic brain injury in its reporting. So just want to look at the WHO global health estimates and look at the data on cause of death and disability. And this data is from multiple sources. And if you look at the top 10 global cause of death, we in 2019, we don't see any mention of traumatic brain injury in these top 10 global causes of death. And the reason is because there is no data. Then if you look at the top 10 global causes of disability, the daily, the adjusted life years, then road injury is the number 6, but really there's no, again, mention of traumatic brain injury, neonatal conditions, ischemic heart disease, stroke, etc. are, of course, all are there. And this study, which was done in 2019, and this was sent to me by Professor Andrew Maas from Belgium, and that was when we started thinking about what to do about it. And if we look at this typical slide, there is no mention of traumatic brain injuries, but there is transport injuries, unintentional injuries, and self-harm and violence right at the end of this scale. And then if you look at the leading causes in 1990 and 2021, again, injuries are, road injuries are at number 19 or at 14 in 2019. So again, it is much below ischemic heart diseases, tuberculosis, stroke, congenital defects, diabetes, and all these illnesses. But the facts are different, and we know that, and we know that there are a large number of traumatic brain injuries. And if you look at this paper, it shows that, and this is from the Lancet Commission, and that is where the focus came from. And it says basically that systems of care for people with TBI vary greatly, and disconnects exist in the chain of care. Strong evidence to support treatment guidelines and recommendations is scarce, and current treatment strategies insufficiently target the needs of individual patients, generally being based on one-size-fits-all approach. Because again, because we have no data on the number of injuries, traumatic brain injuries. And that accurate epidemiological monitoring and robust health economic data collection is essential to prevention programs and healthcare policy are lacking. And it highlights priorities and provides expert recommendations to reduce the global burden of TBI, emphasizing the need to develop and implement policies to improve prevention and systems of care, and to invest in TBI research across the range of disciplines there. This study says that you need to standardize nationwide neurotrauma data collection, which can facilitate international comparisons and bidirectional learning among healthcare governments. And this paper again talks about, it's a long overdue priority regarding the near-action neurotrauma registries in LMICs. We in Northwest General Hospital have been collecting data, so it's not a a very difficult thing to do. You all know of this very important worldwide variation case with quality of care in the GNOS and now the GUTBI study from Cambridge. And I think this is a very important step and which is going to help us really trying to develop this data processes. And of course, when we did the Peshawar recommendations in the MICs, for that also to implement that, and these were policy guidelines for government officials, to ensure that these policies are implemented, we need to have data to show them. So why should it be notifiable? Obviously, it's going to improve surveillance. There'll be early detection and intervention. There'll be improved data collection research, better resource allocation, which is very important, preventing secondary complications and policy development. Of course, there are a large number of challenges and limitations to reporting neurotrauma or traumatic brain injuries, underreporting incomplete data, diversity of neurotrauma cases, variability in diagnostic criteria, resource constraints, privacy concerns, stigmas and reporting bias, very important international harmonization, then the data management and analysis of it, and policy and regulatory barriers, and limited healthcare provider awareness. So what we are thinking of and what we are planning to do is to establish national registries or database looking at and help from the GUTBI registry, develop a standardized protocol, train healthcare providers, strengthen referral systems, and then importantly, improve public education and awareness. And obviously, we need to allocate resources and we need to increase investment in research and development, strengthen healthcare systems and infrastructure, increase collaboration to different sectors, and then develop guidelines for reporting and surveillance. So the proposed plan of action again is, first of all, case definition and classification, building a coalition of stakeholders, which we are slowly developing, raising awareness through webinars, seminars, engagement with policymakers, reporting mechanisms, data collection, and again, collaborate with healthcare providers. So we have to do all that, obviously, and then we have to monitor the progress. So basically, we are starting a local pilot project with developing a portal, and we're going to start 4 hospitals locally to collect the data. And the data has to be from the emergency room. And the idea would be that any patient coming to emergency room for TBI or complaining of head trauma would be collected, analyze the data, and then use this data to lobby the Department of Health and Ministry of Health. And then we would look at demonstration projects internationally, develop a portal again, and then to lobby the governments. And the idea to lobby the governments would be that they would need to go to make a resolution to go to the World Health Assembly to talk about having a traumatic brain injury as a notifiable condition. So anybody who wants to collaborate can email me, and we are looking for sites both in high-income countries and low-income countries. And then we plan to lobby the G4 Alliance as well, which is an alliance of more than 85 organizations from 135 countries. We are hoping to talk to them in May when the World Health Assembly occurs, and then use the governments, use the G4 Alliance, use the NGOs to push for resolution in the World Health Assembly. So obviously, to make neurotrauma a notifiable condition, it's important to save lives, improve patient outcomes, contribute to better understanding of these injuries. I would like to bring your attention to this global part of the Neurosurgery Journal. So if you want to send your papers to this journal. Thank you very much. Thank you.
Thank you. Thank you, Tariq. So it is a really very informative lecture. Maybe Dr. Petra? Or maybe Peter, any comment to Tariq?
maybe I could just, Tariq, it's a fantastic initiative, and I think we're all really keen to support it. And as you know, we're going to the World Health Assembly. I guess the challenge, governments are under a lot of pressure from many different sources, and I think the challenge is going to be how we actually get this resolution over the line. Do you think, I mean, clearly the data is important, but logistically, what steps do you think we really need to undertake? I mean, the concept's brilliant, but actually getting this across the line, have you got any other further thoughts about how we're going to strengthen that evidence base?
Yes, so actually, we are trying to place this model on, if you remember the resolution on prevention of spina bifida and foliate fortification, which was pushed by, firstly, from Colombia by Kemal Rotme, and very strongly pushed by the G4 Alliance. And what happened was that they were able to convince the government in Colombia to send a resolution to the World Health Assembly. So the idea to collect this data and use, hopefully, the GU-TBI model, use rather the GU-TBI data, plus additional data from the ERs, and be able to get a number of countries get involved, and hope to be able to lobby with the governments, with the Ministry of Health, so that they can send it. And then the G4 Alliance is going to be hopefully our vehicle, which is going to lobby in Geneva. Obviously, it's not going to happen this in this May, but we are looking forward to maybe next year. In the meantime, we'll be able to collect the data and develop the pressure and the force to do that. Thanks.
No, Tariq, you're doing a fantastic job driving this, so we're all very grateful. Thank you.
Thank you very much, the boss. So maybe Dr. Nakagawa Sensei, any comment?
And sorry, the main focus is this will be a way to put it in front of everybody for resource allocation, help in prevention of TBI, and help in the rehabilitation. Because until and unless we are able to have a resolution in the World Health Assembly, which would then make the countries bound to report every 2 years to the WHO on the progress which they are making on this notifiable condition. And that is the way we are going to be lobbying everybody for that. Thanks.
Thanks so much. So Nakagawa Sensei, any comment?
そうですね。I have a look at your website right now, and really interested in what you're doing. And I do not have a specific comment or discussion at today's presentation, but very impressed, and would like to have a future discussion. Thank you very much.
Thank you very much, Tariq. So I think prevention and also the prognosis at that very early stage, we can tell the family about the prognosis of the trauma, and also the rehabilitation, early rehabilitation is very, very important. Thank you very much. I always admire your worldwide research. Thanks so much. So today, our final, thanks so much. Our final speaker is Prof.Virendra. So her talk is Pitfalls in Decompressive Hemicraniectomy for neurotrauma. Lynne, please.
Okay, thank you. I'll just share my screen. Can you see already screen?
Yeah.
Yeah. Okay. Start. Okay. So title is Pitfalls in Decompressive Hemicraniectomy in Neurotrauma. Disclosure. Actually, from the talk of Professor Hutchinson, and also some things were mentioned also by Professor Nakagawa. So I'll go briefly for these objectives that I will discuss. what is the use of decompressive hemicraniectomy neurotrauma, and then the pitfalls that you will encounter, the outcome and complications and management of these complications. So we all know the classification of primary and secondary injuries. Okay, so and the primary injury is the one that's induced by the mechanical force at the moment of injury. And of course, the secondary injury is the one that is delayed after the moment of impact. It's not mechanically induced and may superimpose injury on the brain already affected by the mechanical injury. So injuries can also be classified as focal and diffuse. So whenever we do operations, we have, it's not just the surgeon or the neurosurgeon that has a problem or when the complications happen. So we need to consider patient factors and also surgeon factors. So patient factors can be existing comorbidities, other injuries, immune system, age, race, location, and type of injury. Surgeon factors is the expertise, the experience, the external resources. So primarily, what we have been sworn to do is to do no harm. I will just present this unpublished data in our local setting here, the epidemiology and outcome of traumatic brain injury patients in the area where I practice. So we were able to collect, 2,247 traumatic brain injury patients from January 2015 to June 2018. So the mechanism of TBI was recorded in 1,855 patients. So road traffic accidents is the leading mechanism, accounting to 79%, and 25% of the cases were due to other mechanisms, including ruptured aneurysm in which the patient fell, and falling object and electrical injury. So this is the demographics. In summary, there's like mild traumatic brain injury occurred in 48%, moderate in 26%, severe in 26%. The surgical cases was 7%. The most common was craniotomy and decompressive craniectomy and burr hole. So when we are discussing hemicraniectomy, we say that unilateral decompressive craniectomy involves the removal of the bone from the frontotemporoparietal region at least 12 by 12 centimeters or even more than 12 centimeters, 12 by 15 centimeters. Then if you say a bifrontal decompressive craniectomy, you extend it from the floor of the anterior cranial fossa to the coronal suture and, of course, involving the middle cranial fossa bilaterally. There is also the wide opening, of course, of the dura to accommodate the brain swelling. So I will cite this one. It was already mentioned before. The current status of decompressive craniectomy and the traumatic brain injury involving our speaker also, Professor Hutchinson, and also the other things that, and Professor Tariq, in which they mentioned that these are the different subtypes of traumatic brain injury in which decompressive craniectomy is used. So we have comatose patients with acute subdural hematoma with associated brain swelling. You have, you usually do primary decompressive craniectomy. This is usually unilateral and within 24 hours. But in some papers, it can extend to 48 to 72 hours. Next, you do patients, decompressive craniectomy in comatose patients with intracranial hematomas or contusion with substantial mass effect, more than 5 millimeter midline shift, and or uncal herniation. Sometimes these patients have ICP monitors before, and then if there is a persistent increase in intracranial hypertension, decompressive craniectomy is done, which means that the decompressive hemicraniectomy was a secondary decompressive hemicraniectomy. And patients who had craniotomy for evacuation of ICH, but subsequently developed uncontrolled intracranial hypertension can undergo decompressive craniectomy due to the increasing mass effect. Less frequently, you can have close traumatic brain injury with diffuse brain swelling without significant intracranial hematomas or contusion in gunshot wound with gross hemorrhage and swelling and blast injury. So main RCTs, these are already already mentioned, and contrasted by our previous speaker, Professor Hutchinson. The role of decompressive craniectomy was craniectomy in moderate intracranial hypertension. Decompressive craniectomy should not be used as a neuroprotection in well-resourced settings. And also another one was the rescue ICP, in which secondary decompressive craniectomy can be helpful as the last tier resource for this refractory and severe intracranial hypertension. And rescue ASDH was also mentioned. And there was also a mention there in their paper of 5 centers in China in which 12 by 15 centimeter decompressive craniectomy versus a limited 6 by 8 DC in severe TBI was done with refractory intracranial hypertension. Of course, there was they found out there was lower mortality rates in the 12 by 15 centimeter larger decompressive craniectomy, and there was more favorable outcome. So now, this is the comparison of the DECRA and the rescue ICP trials. So now we go to what are the things that we should check before doing these things. So bleeding, patient and surgeon factor, inadequate hemostasis, compromised patient, you check the bleeding parameters, and also constantly check if there is post-operative hematoma. So checking the bleeding parameters, you also check, of course, the medications that the patient has been taking. Level of expertise in the operation, factors like location of the hematoma should also be considered. So repeat CT scan can be immediate and 48 hours later to monitor. So pitfalls, number one, there's always a possibility of infection. It can be both a combined patient and surgeon factor. It can be inadequate antibiotics in a limited resource setting, compromised patient, equipment and technique in the way that the operation was conducted. And of course, abscesses can happen. And if it's a craniotomy, an osteomyelitic bone flap can be there, and of course, it has to be removed and debrided. So possible complication of decompressive craniectomy, CSF leak is mostly a surgeon factor, inadequate dura closure, as was cited by Alwade et al. In World Neurosurgery in 2019. They had 2016 patients, 112 was open, dura, 114 was closed. They said that there was no statistical difference in the incidence of CSF leak and the surgical site swelling. So a study by Tae-Chok Jong, the efficacy and safety of decompressive craniectomy with non-suture duraplasty in patients with traumatic brain injury. There was also no statistical significance in the safety. So management for CSF leak, you can do from lumbar drain, of course, to reoperation if it's there's no infection, and also adequate antibiotics to prevent post-traumatic meningitis. So another one is brain infarction in intracranial herniation. So extracranial herniation. So how does this happen? Of course, usually it's inadequate cranial opening, and you are not able to address the brain well. So this happens. So with this, you should always have more than 1.5 centimeter. If you have more than 1.5 centimeter of herniated brain tissue through the center of the craniectomy defect, this means that the inadequacy of the craniectomy. Why? Because if it's adequate, there's compression and kinking of all the vessels and even the venous drainage in that area. There is altered hydrostatic gradients from the capillaries after the decompression, and the edema can progress from the cerebral reperfusion. So what do? Usually you can do augmentative duraplasty, or later on we can, a lot of people propose from the studies, the earlier the replacement of the bone can be done, the better, to prevent all this extracranial herniation. So others, wound complications after decompressive craniectomy, of course, dehiscence, ulceration of the necrosis. So it has to be that the large size of the scalp flap should be done. and prevent injury to the superior temporal artery. So as much as possible, if we are able to preserve the STA and limit the posterior extension to less than 5 centimeters from the pinna. So syndrome of the trephined or sunken flap. This was first reported by Grant and Norcross in 1939. This is already the lack of the bony support. When you take out the bone, you alter the cerebral blood flow, and there's advent of cortical dysfunction. So again, we were saying that a lot of studies say that early cranioplasty within 8 weeks after decompressive craniectomy will help prevent this type of complication. So seizures, this is a very common possible side effect. Postoperative epilepsy, because there's reduced epileptogenic threshold. There is increased hyperexcitability because of the injury also. And you can always titrate the dosage, increase or add another anticonvulsant after the first 2 weeks after this, if the seizures occur. So subdural hygroma, this is a frequent complication after decompressive craniectomy. We have the cerebral blood flow abnormalities. There's increased cerebral perfusion. There is also disruption, of course, of the subarachnoid pathway. So this can be subdural, subgaleal, or interhemispheric. So it is suggested that early pressure dressing at the 7th to 10th day post-decompressive craniectomy is done. And you can drain it if there is pressure and if there is ball valve effect. Hydrocephalus. So again, with the altered cerebral blood flow, cerebrospinal fluid flow dynamics, you can have post-traumatic hydrocephalus and post-decompressive craniectomy hydrocephalus. So you would need to do CSF diversion and also early cranioplasty in decompressive craniectomy. What are the risks? A lot of papers say advanced age or a higher score in the Fisher grading, or low post-resuscitation GCS, possibility of CSF infection, and also delayed cranioplasty were all cited as possible causes of post-DC hydrocephalus. So again, another, of course, possible side effect is when the patient falls, there will be injury to the unprotected cranium. So again, I would like to thank you for the kind attention and the opportunity to speak in the ACNS ASEAN Congress, and also Professor Kato and Professor Bongi for inviting. Again, I will invite you all in May 2026 for the 18th Asian Australasian Conference in Manila.
Okay.
Thank you.
Thank you so much, Lynne. What a wonderful talk. Very common, but it's quite difficult to solve some problem, I think. So maybe Tariq, so any comment for her, please?
Yeah, thanks so much, Lynne. Really, you're doing an amazing job. We were working, starting from scratch, developing neurosurgery, neurotrauma, wonderful. And we would love to visit when you're doing the boot camp and, of course, the conference in 2026. Thank you so much. And also, we would love to have you part of this, having neurotrauma as a notifiable condition, and take your center as one of the centers to work with us. Thank you.
Of course, I'll be part of it. Thank you so much, Tariq.
Thank you very much. So maybe Peter?
Yeah, Lynne, that was
Please.
a great talk, and you know, the complications are so important, how we manage them. What is your current antibiotic prophylaxis for trauma neurosurgery? Do you use one dose or multiple doses, and which antibiotic do you tend to choose?
We usually use the second generation cephalosporin.
Yeah. And do you have a one dose or 3 doses or a number of days? How long do you continue antibiotics for?
Actually, when you say prophylaxis, we have to discontinue it after, but sometimes it is really the comfort. It's not really the, you know, the situation. You have crowded rooms, you bring out the patient in the wards, and you know. So we continue it to like a week. So
Okay.
Typical LMICs, it's maybe more for us than for the patient, I wonder.
Yeah. Yeah.
Okay.
Yeah, I think you're treating the surgeon more than the patient sometimes.
yes.
Okay, thank you very much. So, Atsuhiro?
Lorraine, thank you very much for a wonderful presentation and sharing your great experience to us. I apologize if I missed if you already commented, but what is the period that you are putting your bone back? Do you have any protocol one or kind of average, or this is always kind of a discussion matters?
Okay, that is the problem. In my center, we don't actually have a bone bank. So when I studied in residency, we used to bury it in the abdomen. But throughout the years that I experienced it, the patient is already well. They do not complain of any headache. They complain of the bone there because they cannot come in and have it replaced for some reason, mainly financial. So and when the time you come to replace it, the bone is already smaller, so it has resorbed. So you just you throw it. So that's two. And I have seen in my other colleagues there were also times that there was hematoma in the abdominal, so it infected. So at some centers though in our country, they autoclave the bone, they wrap it, and then they preserve it in the refrigerator, and then they get it again and then autoclave it several times. But we are now actually because a lot of studies has been saying that the autologous versus the others, the replacement cranioplasty is almost the same. So we did not actually put the bone in the abdomen anymore. And we don't have the bone bank. And whenever we do cranioplasty, we are able to secure funding as of now for titanium or cement, like bone cement.
Okay. Thank you very much.
Thanks. So maybe Evelyn from Peru? Evelyn? Okay, so this was?
Thank you, Sensei. Two questions to the speaker. Thank you, madam, for the excellent presentation. How do you manage the postoperative hydrocephalus following decompressive craniectomy? If it is in the 8th or 9th postoperative period, after 1 week. This is number one. And number two, any experience with spontaneous bone resorption following cranioplasty?
Okay. I think I wasn't able to understand the second question. Kindly repeat the second question.
In 2 cases of mine, I have done the cranioplasty with autologous bone, but there is spontaneous resorption of the bone.
Okay. So the first question with the hydrocephalus, there is now, if there is still, the bone has not been replaced and you already have symptoms of hydrocephalus, and then you had monitored that the ventricle has already been enlarged, then now you need to balance whether you put the bone back and then put the or do cranioplasty and do a shunt. So because because we all know that putting in a shunt in one area, it may bring down more the pressure, and also worsen the sunken flap syndrome that the patient may already have. So what happens now is sometimes we address first, if the patient is awake and it's just the problem of the sunken flap and the hydrocephalus, then we put the cranioplasty and then observe the patient, monitor the patient, and if there is still symptoms of hydrocephalus, then we shunt the patient.
Okay.
The second question, if what happens if the bone is resorbed already?
Yeah, okay. After cranioplasty, the autologous bone was resorbed.
Yeah. So
any experience with that, and how did you manage?
Yeah, if it's already resorbed, then we actually
the thickness of the bones is continuously reducing.
Okay, so
over weeks and months.
sorry. How long?
Over 3 months, continuously the thickness of the bone
Okay.
resolving.
Yeah. The experience is that it's recommended that within 3 months, like you are able to replace it, the earlier the better, within 3 months. Because longer than that, my experience is the bone has already started to resorb.
Okay.
Okay.
Okay. Thank you.
So
Thank you.
the final comment or question from Dr. Parks from Mumbai.
Yeah, so I was having the similar question that the post-traumatic hydrocephalus, do you do lumbar puncture for a trial before you put shunt or not in post-traumatic hydrocephalus, or whether you do first the cranioplasty and see after cranioplasty the hydrocephalus has disappeared or not. If not disappeared, then put a shunt.
Okay. If the patient is fully awake, and it's all more of radiological that there's developing hydrocephalus, you can actually measure the pressure with the lumbar puncture, and then decide if it's really high. Then you may be shunting it, but also take note that with the decrease in pressure within the ventricles, you may, as I said, can also predispose the patient more to sunken flap syndrome. I have also seen cases in which shunt was done and there was subdural hematoma. So that
Yes.
can happen actually. Yeah.
Thank you. Thank you so much.
I think it's a very good thing if you read the recommendations from the group, from the Cambridge group, which had got together around decompressive craniectomy, whether to shunt or not, whether to put in the EVD or what to do. I think it's a good read there. Thanks.
Yeah, I think they have a recommendation.
So, Peter, you want to make some comments?
I just want to ask a question to all the panelists. What is your experience in facing patients with traumatic brain injury? Because we do a lot of studies looking at their morbidity and all that. But anyone has done studies that have gone past 5 to 10 years with patients with endocrine problems presenting to, because they don't present to us sometimes, they present to the endocrinologist. But I have been seeing a few patients because now I tend to actually check their bloods, and I notice, they come back with problems like lethargy, concentration issues, a lot of times it's, connected to their endocrine. Any of you all have any experience in that for, post-decompressive craniectomy complications?
Peter?
We
Peter,
do
please.
have, so I think post-traumatic endocrine problems, particularly pituitary failure, is probably underdiagnosed. So the challenge is to test these patients properly requires a lot of dynamic testing from endocrinology, but we have developed a 9 a.m. screening blood test that can be done to screen for most of the common hormone abnormalities. So I'm happy to share that. So that can be done by the family doctor, usually at weeks or months following the injury, and it'll test the thyroid function, some cortisol issues, growth hormone, without having to involve the endocrinologist. And then if those tests are abnormal, then we would refer to endocrinology. But you're right, it's really important because this is something that is correctable.
Tariq?
Yes, definitely. Especially in our setups, we're not doing any screening, I think, unless really one considers. But thank you for this very important point. I think the neurosurgeons must be made aware of these conditions to ensure that they are looking at it. Thank you, Sharon.
Thank you very much. So, the Sharon is okay?
Yeah.
Okay, thanks. So it's almost at the end of the webinar. I think before me, maybe Dr. Liu, the secretary of the ACNS, maybe one comment from Dr. Liu.
Yeah, thanks, Prof. and thanks to all
You're in the
our
car.
respect. Yeah, sorry. To our speaker. I think especially for neurosurgeon in Asia, traumatic brain injury very close to us because most of us learn our first craniotomy on trauma patient, and we are delighted to see more medical therapy now available, and that actually improved the interest among the intensive care physician, and where our patient now get better treatment in ICU and as also including those rehabilitation. And we hope that also among neurosurgeons, we give more priority to traumatic brain injury patient. Thank you, Professor.
So thanks so much. So just I want to tell that thank you very much for your very, very important, very informative talk for all of us. So we learned a lot from all of you. And I think still the trauma is we need the breakthrough because so many factors to overcome. Sometimes I went to the Asian countries, so still very far from the control of the, even though the helmet, something like that. So I think in the future, the collaboration and also the universal treatment for every country. So I think hopefully the result can be the equal in any countries. I think Dr. Tariq, he mentioned about the rehabilitation, the prevention and the prediction is very, very important because some of the patients become a vegetative state. But I think if we can search or we can know that at the very beginning after trauma, so maybe we can do the more treatment for them, I think. So that means is image is another very important. And also, of course, Peter mentioned about the surgery, the importance. So I think neurotrauma is very still very attractive, and also so many field to research. I think so. Maybe there are two giants, the Peter and also the Tariq, can lead us in the future. Thank you so much for today's webinar. Very fast. Thanks so much.
Thank you.
Thank you for asking us.
Thank you, Tariq.
Thank you.
Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye, everyone.